بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد. Now, what's the intended learning outcomes of this lectures? Now, in this lectures, we will speak about the natural immunity and the predisposing factors for any microbial keratitis. Also, we will discuss the manifestation and the classifications of bacterial keratitis, the different types, and of course, the management, including the laboratory investigation and the microbial assessments. And finally, we will discuss some recent updates about the microbial keratitis. Now, let's start first with the natural immunity and the predisposing factors for microbial keratitis. Before I speak about the infectious keratitis, I will just say a few words about the leading major causes of blindness worldwide, because corneal opacity regarded as the fifth leading cause of blindness after refractive errors, cataract, glaucoma, and age-related macular degenerations. And of course, this depends on the country. It differs from country to country. In the developed countries, perhaps the leading cause of blindness is age-related macular degenerations. In our countries, it differs. It might be trauma, it might be glaucoma, and so on. So corneal opacity, one of the major leading cause of blindness, and among corneal opacities, infectious keratitis is a leading cause of corneal opacity. And among infectious keratitis, bacterial keratitis represent the major cause of infectious keratitis, reaching between 75 to 80% of the microbial keratitis is due to bacterial keratitis. And of course, the second major infectious cause for infectious keratitis is fungal. And this is also differs from country to country, because in the developed countries, the major cause of infective keratitis is viral keratitis and acanthamoeba because of the prevalence of the use of contact lenses. However, in our countries, still we are suffering from bacterial and fungal keratitis because the major precipitating factor is a trauma. So the prevalence and the incidence of infectious keratitis differs from country to country, and we need to establish a studies on our countries to determine what are the causes of corneal opacities, what are the causes of infectious keratitis, what are the causative organisms. Another thing that the infectious keratitis has a major burden in the human health from many aspects, that the duration of the disease can reach up to 6 to 8 months follow-up, especially in fungal keratitis. And as I said, that the infectious keratitis as a major cause of leading of blindness. Now there is a growing emergence of antimicrobial resistance because of the availability of antibiotics over the counter, and the doctors, they are abusing the use of antibiotics, so that there is an emergence of antimicrobial resistance, especially for fungal and bacterial keratitis. And the WHO, they said that by the year to 2050, the people will die from antimicrobial resistance more than dying from the cancer. So this is very major alarm that we should restrict our use of antibiotic to the needed patients, and we should not use a very strong broad spectrum antibiotics for a simple pathologist. For example, if you find a patient with mild conjunctivitis and you give him fourth generation quinolones, this will result in the development of drug resistance. Now, another major burden of infectious keratitis is the cost, because the cost of the doctors is high, expensive. The patient cannot afford for visiting the treating doctors weekly for 6 or 8 months, and the cost will be very high, and this is lead more burden to the management of infectious keratitis. So the WHO saying that there is a silent epidemic of infectious keratitis because of the prevalence of the antimicrobial resistance, and infectious keratitis should be managed properly, and should be of your first suspicion when you face a case of red eye, and you should treat promptly, otherwise the patient will suffer from the complication of the infectious keratitis. Infectious keratitis, as the name implies, it means there is infections and inflammations of the cornea. Keratitis stands for inflammation of the cornea, and infections means that the causative factor for the inflammation of the cornea is due to infection. And as you know, infectious keratitis is the most common cause of non-trachomatous corneal opacification and the fifth leading cause of blindness. And among infectious keratitis, bacterial keratitis is the most common cause of microbial keratitis. And the microbial or the bacterial keratitis rarely happens in a normal cornea, unless for very limited situations in which there is some organisms are capable for penetrating normal cornea. However, the normal anatomy of the cornea is very precious, that protects the cornea from being invaded by organisms, as we will explain in the natural immunity and the natural immune system provided to the cornea. And one of the important risk factors for the infectious keratitis is the contact lens. It is found that the risk for contact lens related infection is almost 10-fold higher than those who don't use contact lenses. And the risk is higher still in patients who wear contact lenses overnight. So we will go more in details regarding the natural immunity of the cornea, and we will come across the different scenario and the different clinical situations. Since the cornea is a very precious structure and it is tightly protected from being exposed or at high risk of being invaded by any pathological organisms, one of the ocular defense mechanisms that's naturally present is the presence of the lid. Now, normal structure and normal function of the lid is very important to maintain normal integrity of the cornea and the corneal epithelium. And the presence of any abnormalities like chronic inflammations of the lid, like chronic blepharitis, or the presence of dacryocystitis, or entropion or ectropion, or the presence of lagophthalmus, all of these abnormalities will lead to abnormalities in the precorneal tear film and make the cornea susceptible for being invaded by pathological organisms. So this is a natural immune system provided so that it protects the cornea from being exposed to the organisms. The other important natural ocular defense mechanism is the presence of tear film. As you know, the normal tear film contains many lysozyme enzymes that protect and clear the cornea from being invaded, and it washes all the pathogens through the nasolacrimal duct and get excreted. So normal tear film is important for a normal and healthy cornea. Also, the corneal epithelium, it is tightly packed with the zona occludens that prevent invasion of organisms within the layers of the cornea, and very minimum organisms that can penetrate or invade a normal epithelium, namely like the Neisseria gonorrhea, the Corynebacterium diphtheria, Haemophilus aegyptius, and the Listeria monocytogenes. All these organisms are capable to invade even a normal cornea. However, other organisms, they need a precipitating factors, and also they need a trauma or inoculation of the organism within the layers of the cornea to be able to induce inflammation or keratitis within the cornea. But these organisms that I mentioned here, they are capable of invading even intact cornea. So normal corneal flora also is the normal ocular flora is very important. So any judicial use of topical antibiotics, this will lead to disturbance of the ocular flora, and this will make the eye more prone for exogenous organisms. So this is also an important natural immune mechanism. Now, as we have spoken before, that the cornea is very precious structure, and it is not easy to be invaded by organisms unless for specific types of organisms. Otherwise, generally, the invasion of the cornea by any organism need a precipitating factor and predisposing conditions. Now, the common predisposing factors for ocular infections, or that's precisely the bacterial keratitis, is that the presence of trauma. Now, trauma, whatever type of trauma, is a chemical or mechanical or physical trauma, or a contact lens wearers, people who are using contact lens, they are more exposed to trauma to the corneal epithelium. And this especially in the Western and developed countries. The contact lens wearer is very important predisposing factors in the Western countries. However, the trauma is common in our country and in the developing countries. Other important predisposing factors is the judicial or the use of topical steroids that disturbs the immunity of the system, as well as it interfere with the microbial flora which is present in the eye. So this will increase the susceptibility of the cornea for being invaded. Other risk factors like the ocular surface problems and the presence of recurrent corneal erosions, and also the dry eye is very important. Also, the presence of lack of thalamus or loss of sensation or the abuse of topical anesthetics and the contamination of the ophthalmic solutions or use a contaminated fluids. Another thing is the, as I said, the dryness and the xerophthalmia, presence of trichiasis, entropion and extropions, and also dacryocystitis. And this is very especially in people with chronic dacryocystitis, on which pneumococcus is very predominant in these patients, and the risk of hypopian ulcer or ulcus serpens due to pneumococcus is very common. Other systemic diseases like the diabetes mellitus or the presence of HIV or the prolonged use of steroids, as I said, that will affect the immunity of the system, make the cornea more prone and more susceptible for infection. Generally, as I said, that the trauma is the most common cause in our country and in developing countries, and the use of contact lenses, especially the soft contact lenses, is very important cause in developed countries and in the Western countries. Now, for contact lenses as a predisposing factor for infectious keratitis, especially in the developing countries, these contact lenses related infectious keratitis are especially people who are aphakics. The incidence of infectious keratitis is more, and also in patients with corneal transplant, an attempt to manage astigmatism, they use a toric contact lenses, and the chance of having infection is more. Also, patients who are wearing the bandage contact lens for a long time, and people with poor hygiene and smoking. Now, the mechanism of contact lens and related infectious keratitis mainly related to the induction of hypoxia or slowing down of the epithelial hemostasis. Now, the hypoxia will lead to endothelial dysfunction, and this will lead to epithelial edema. And this epithelial edema will make the epithelium vulnerable to be invaded by organisms. And also the epithelial hemostasis will get interrupted, so the proliferation rate will be retarded, and this will disturb the integrity of the intact tight junctions between epithelial cells, and this will lead to reduction of the proliferation and also the migration and exfoliation of cells, and make it more vulnerable to infectious keratitis. This is an example of the infectious keratitis induced by contact lens. As you can see, by Pseudomonas keratitis, you can see that the edge of the abscess is related to the contact of the contact lenses, and those also there is a stromal infiltration in this other slide. So it should be taken in consideration that in the history, if the patient is using contact lens, we should make sure about when there is an infection of the cornea, we take samples from the contact lens itself, also from the contact lens solutions, to make sure and to identify the causative organism. Still in the context of the risk factors for the corneal infections are those conditions which will lead to the ocular surface abnormalities. Ocular surface abnormalities leading to abnormalities in the tear film itself, or irregularities and abnormalities on the surface of the epithelium. There are many conditions that disturbs the ocular surface. Some of them like the cicatricial pemphigoid, Stevens-Johnson syndrome, atopic keratoconjunctivitis, and also radiation injuries, and also vitamin A deficiency, and the presence of chronic epithelial defect as seen in post keratoplasties, or any post-corneal surgery. You know, after any corneal surgery, either by the presence of loose sutures or persistent epithelial defects or irregularities of the surface, all this will lead to predisposition for infectious keratitis. Also, some systemic diseases like diabetes mellitus and vitamin A deficiency also make the cornea more prone for infections. Especially in diabetes is the Moraxella and Mycobacterium infections, as you can see in these pictures, when there is a corneal ulcer with infiltration to the stroma with the Moraxella keratitis, and also with the Mycobacterium keratitis, as you can see in this picture. Also, this is a post-keratoplasty when there is a loose sutures. This make continuous irritation in this area, and this will lead to infectious keratitis. So it is advised that patients with post-keratoplasty, they should be followed carefully for any loose sutures to be removed in time, so that prevent the occurrence of infectious keratitis. Now, if we look to the pathogenesis of the corneal infections or the corneal ulceration, usually there is a precipitating factors, and usually there is a predisposing situations. Now, the common precipitating factors for corneal infections is the presence of injury, any corneal injuries in the form of corneal abrasions or the injury due to contact lens wearing. This is usually the trigger for the initiation of corneal infections. And the precipitating factors that we have spoken before, the presence of unstable tear films or decrease in the immunity or dryness or coexisting systemic or local diseases, all these are precipitating factors. So whenever there is an injury and there is a precipitating factors, this will lead to adherence of the bacteria to the surface of the cornea. And this adherence of the bacteria, along with the certain proteins that help to adhere the bacteria to the surface of the cornea, this will lead to invasion of this bacteria inside the stroma. And as you can see here, this invasion of the bacteria inside the stroma with the help of certain proteases secreted by the bacteria, this will lead to proliferation of the bacteria based on the virulence of the organism and also based on the immunity of the host. So if the organism is very virulent and the host immunity is very low, so there will be very rapid proliferation. Especially the medium is very suitable in the stroma, as we said that 90% is water. So this is a good media for the organism to multiply and proliferate in this area. Now, it should be noted that without the use of antibiotics, this bacteria will continue to grow, and this will lead to increase the load of the bacteria and lead to corneal abscess inside the stroma. And this anterior stroma will produce certain proteolytic enzymes that destroy the organism will produce proteolytic enzymes, destroy the stroma and the collagens, and this will increase more the infiltration of the organism deeper into the layers of the stroma. And sometimes the bacteria tend to be found at the peripheral margin of the infiltrate and deeper within the central corneal ulcer and the crater. This is based on the virulence and the immunity of the host organism. So this is a general overview of the pathogenesis of the corneal infiltration by the organism, because we said that the cornea is very precious structures, and the presence of tight junctions between the epithelium and the zona occludens. This is forms a natural immune system that protects the cornea from being invaded by any organism. It is not simple for any organism to invade the cornea, but in the presence of a precipitating factors and predisposing situations, this will lead to inoculation of the organism or the bacteria to go inside the cornea and sitting and colonize within the stroma of the cornea, which is a good media for nutrients as well as for water, and this lead to proliferation and multiplication of the organism and release of the toxins and proteolytic enzymes that augment the problem. Now, if we speak about the different stages of the corneal ulcer from the beginning of inoculation of the organism till the healing of the corneal ulcer, it starts by an progressive infiltration or stage of infiltration of the organism within the epithelium, and then to the lamellae, superficial lamellae of the stroma. And there will be a rapid mitotic activity of the organism and release of proteolytic enzymes and the toxins of the organism. And this will create severe inflammatory reactions within the stroma. And as a result, there will be significant haze and infiltration within the stroma. Now, the second stage, as a result of this severe inflammatory reaction and the proteolytic enzymes, there will be melting and melting of the part of the stroma which is involved, and there will be sloughing of the overlying epithelium, and this is the stage of active ulceration. And at this stage, the ulcer is not clean, and the base of the ulcer will be full of the organism, and there will be severe active inflammations, and you will see even the edges of the ulcer are creeping or undermining below the surface epithelium, as you can see here. So this is a stage of active ulceration. The third stage after the active ulceration and with the use of antibiotics, the ulcer will go into stage C, which is stage of regression, in which there will be a reduction of the undermining of the active edge of the ulcer, and there will be some mitotic activities of the epithelium to cover the part of the ulcer or the crater of the ulcer. And the ulcer here is regarded to be clean, no more organism will be there, and the epithelium will start to grow over the ulcer. This is stage of regression. And the fourth stage or the last stage is a stage of healing or cicatrization, and the structures will start to be healed, the epithelium by rapid mitotic activity, and the Bowman's membrane will not heal. It will be replaced by fibrous tissues, even the stroma. There will be a replacement of the normal collagen regular pattern of the stroma with laying down fibrous tissue by the fibroblast production. Also, there will be invasion by new vessels and new vascularization of the area. So this is a stage of cicatrization. Now, as far as the clinical features of bacterial keratitis, these features are dependent on two variables. Number one, on the virulence of the organism and the causative organism. The second thing is depends on the response of the host immune system itself. So the symptoms may be mild or severe based on these two factors. So there might be mild pain or severe pain. There might mild congestion, severe congestion, mild diminution of vision or marked diminution of vision, and so on. Also, you'll find congestion and discomfort and redness of the eye. So photophobia can be seen as a symptom of the bacterial keratitis. The signs also depends on the virulence of the organism and the reaction of the immune system of the host. So it ranges from mild lid edema and chemosis to a severe lid edema and chemosis, ciliary congestion, small pupil, anterior chamber reaction, cells flare to up to hypopion. You will might document the elevation of the intraocular pressures, and you will find a muddy iris and so on. So the clinical presentation is the variable depends on these two factors. Now, if we revise the possible complication that can happen from keratitis, commonly from ulcerative keratitis, can be classified into complication due to non-perforating corneal ulcer and complication due to perforation itself. Now, for the complication for a non-perforated corneal ulcer is summarized by 4S, and this stands for secondary iridocyclitis, as you can see here in this picture, severe iridocyclitis, and associated with keratitis, and all the complication of the iridocyclitis in the form of posterior synechiae and secondary cataract and so on. Also secondary glaucoma because of the presence of large hypopion, including more than half of the angle, and this is a plasmoid in nature and high protein content. This will lead to occlusion of the trabeculum and lead to secondary glaucoma. Also, the melting of the sloughing of the cornea will lead to a desmatocele or a duocele, as I explained before. The duocele, which is usually due to the inflammatory reaction leading to the melting of the superficial layers of the stroma and leaving the duos layer, which is resistant to penetration by organisms. And lately, there will end up by vascularization and corneal opacity formations and lead to nebular or macular corneal opacity, as you can see in this slide. Now, this is for a perforating corneal ulcer, where there is this is the CDAL test for fluorescein when there is a perforation. Now, there is another battery of complications that will happen after the perforation has occurred. We will show them in the next slides. That's apart from the usual opacity, that's the nebula, macula, and leucoma. Due to the perforation, there will be some abnormal scar formation, there will be facet formation, there will be fistula formation, there will be pseudopterygium because the conjunctiva will attempt to close these perforations. Now, if we study in details, more in details, the complication that happens from perforation of the corneal ulcer due to a sudden rise in the intraocular pressure due to sneezing or coughing. So there will be a sudden iris prolapse in an attempt to close this perforation and sudden collapse of the intraocular pressure. This might lead to intraocular hemorrhages in the form of vitreous hemorrhage or suprachoroidal hemorrhage. Also, the lens will be in touch with the cornea, and this will lead to anterior capsular cataract. Also, fistula formation can occur due to if the perforation exactly in the pupillary area, so that the iris will not be able to occlude the perforation, and it will be lined by epithelium and lead to continuous pouring of the aqueous outside of the eye, and this will lead to chronic hypotony and lead to choroidal effusion sometimes. Also, superadded infection will lead to purulent uveitis, endophthalmitis, panophthalmitis, and if there is a scar formation, there will be leucoma adherent, and even anterior staphyloma will occur due to this perforation. So once there is a perforation, there is another cascade activation of another complication that might happen due to the perforation of the cornea. Here in this slide, I would like to emphasize on an important definition and important points. As you know that the corneal layers are 6 layers. Before they used to say it is 5 layers, but it is 6 layers to the discovery by Herminder Dua, the Duas layer, which is the pre-Dismas layer, which is another layer present before the Dismas membrane and in between the stroma and the Dismas membrane. And the importance of this layer is that it is very rigid and resistant to perforation, and as well as it is impervious to air. That's why when they do the DALT procedure, the type 1 bubble will be between the Duas layer and the stroma. However, type 2 bubble will be between the Duas layer and the Dismas membrane. Now, the importance of this Duas layer in the infectious keratitis is that whenever there is melting of the superficial layers of the stroma, usually the Duas layer are resistant to melting, and it will bulge in the center, so that what we see, the bulging is due to the Duas layers bulging, which is lined by the Dismas membrane, which is known as duocele. Instead of the desmatocele, it is duocele. However, the Dismas membrane happens seen, or desmatocele, seen usually in autoimmune diseases when there is melting of the whole layers of the cornea, including the Duas layer, due to autoimmune mechanism. So what bulging you see is due to bulging of the Dismas membrane. It is known as desmatocele. The surface of the Duas layer is usually rough in surface and usually resistant to perforations. And usually in OCT, it is seen covered by the epithelium, and it has a minute or no bulge, actually very minimum bulge. However, in the desmatocele, you will find significant bulge and very smooth in surface, and it is glistening when you see it. When OCT, there will be no any surface epithelium. This is the difference between desmatocele and duocele. Should be kept in mind, because if there is any melting of the cornea, either due to infections, you will find duocele, or due to autoimmune diseases, you will find the desmatocele. Now, to understand the keratitis, we have to understand how we classify keratitis. When I review many sources, I find different levels of classifications to the extent that became more confusing. So I will mention just the different types of classifications available, and then I will stick to one type of classification that I find it most popular by most doctors. That's the clinical classifications, which is a combination for all these types of classifications. Keratitis can be classified based on the etiology or the etiological cause into an infective or non-infective keratitis. Infective means microbial keratitis, which can be bacterial, viral, fungal, and so on. Or non-infective keratitis, that's a keratitis due to other causes, for example, autoimmune diseases or trauma or chemical burns and so on. Can be also classified based on the location of the lesion into a central, paracentral, or peripheral keratitis. Can be classified based on into the depth of the extension into superficial, epithelial, superficial, intermediate, or deep keratitis, and can be classified based on the presence or absence of suppuration or pus into a suppurative keratitis and non-suppurative keratitis. Can be classified based on the presence or absence of hypopyon into a hypopyon ulcer, a non-hypopyon ulcer, and so on. However, the most common clinical classification of keratitis that's suited by most of the doctors is this classification, which is based on all the previously mentioned levels of classification. Can be classified as superficial keratitis or intermediate keratitis or deep keratitis based on the topographic location of the inflammation. Superficial means at the level of the epithelium. Interstitial means at the level of the stroma, and deep, it means deeper stroma and even the endothelium. And each one of these can be a suppurative or non-suppurative, that is associated with pus formation or not. And each one of these can be associated with corneal ulcer or without corneal ulcer, that's ulcerative or non-ulcerative. And it can be also associated with pannus formations, or it can be associated with deep keratitis, which is involving even the endothelium, which is called keratitis profunda. So when we find a lesion in the cornea, we can say that this is a superficial suppurative corneal ulcers, or we can say superficial non-suppurative corneal pannus like this, the inflammation. So you will mention about all these, about the location, the level, and the associated suppuration or vascularization which is present, and so on. So this is the most suitable clinical classification of keratitis. We will stick to this type of classification. Now, after understanding the different classifications of infectious keratitis, and before we go in details to understand about the clinical presentation of each type of microbial keratitis, I would like to emphasize on the importance of the history taking and clinical examination or slit lamp examination. It's very important in cases of infectious keratitis. Now, the detailed history is very important. For example, history of contact lens using, or history of trauma with organic object like wood, or history of swimming in still water, or history of any contaminated water, use of contaminated waters. All these are very useful in the history, in the narrowing or shortening the differential diagnosis of the causative organism. Also, history of use of prior use of antibiotic or use of steroids. Also, the history of the course of the disease, whether it is long duration or short duration, is very important. If you have a fulminant course with very rapid deterioration, this is might be in favor of bacterial infections, especially Pseudomonas or Neisseria. And if it is very slowly progressive or indolent course, is in favor of fungal infections. Also, the systemic associations is very important. For example, history of immune suppression, or history of diabetes mellitus, or history of malnutrition and vitamin deficiency. Systemic diseases like rheumatoid arthritis is very important. All these are very important in the history taking. Now, as far as the slit lamp examination, it's very important to examine the eye properly, as well as the whole body. The eye should examine the lid margin. It's very important to determine whether there is associated blepharitis or any source of infections. Also, the presence of dacryocystitis or coexisting purulent conjunctivitis. As you know, some keratitis is usually associated with conjunctivitis like Neisseria gonorrhea. Also, the integrity of the tear film, or presence of any evidence of dryness, or presence of scleritis. As you know, some keratitis is associated with scleritis like the nocardia and acanthamoeba. Also, examination of the limbus is very important to rule out the evidence of non-infectious keratitis. As you know, the non-infectious keratitis is related to autoimmune diseases, so the limbus should be examined properly for evidence of vascularization or any immunological reactions. Now, apart from the history taking and the examination, now the detailed examination of the corneal pathology in the form of the location of the ulcer, the size of the ulcer, the depth of the ulcer, whether it is superficial, interstitial, or deep, whether it is central, paracentral, or peripheral, is very important. Coexisting of abscess or pus formation, anterior chamber reaction, for example, the presence of uveitis and hypopion. All these are in favor of infectious keratitis. Now, also the configuration of the corneal nerves, the presence of prominent corneal nerves or any other infiltrates or pigmentation in the cornea is very important. Determination of the margin of the ulcer, where is the active ulceration or the progressive edge, and where is the healing edge of the ulcer, is very important. All these are very important to narrow the differential diagnosis of your case. Now, also the relation of the endothelium is very important, whether there is any associated endothelial dysfunction, like cases of disciform keratitis, the presence of keratic precipitates, and also the relation with the hypopion, whether it is stationary hypopion that's not changing its position on head movement, or it is mobile hypopion. As you know, in fungal keratitis, there will be a fixed hypopion because of the fibrous infiltration within the anterior chamber. So the detailed history and detailed examination is very mandatory and very important in cases of infectious keratitis. That helps you to narrow the differential diagnosis, and so that when you start your empirical treatment, you can target the proper drug that's used for that infection. In the examination, among the important point that your duty is to determine whether you are dealing with an infectious ulcer or a non-infectious ulcer. There are some certain points that points toward an infectious ulcer when you look to the debris and the pus at the base of the ulcer. This is in favor of infectious corneal ulcer. Also, the corneal epithelium usually absent, so you'll find a real staining with the fluorescein over the corneal ulcer. This is indicative of infectious keratitis. As I said, also the severe chemosis, severe anterior chamber reactions, and associated conjunctivitis, all these are in favor of infectious corneal ulcer. However, in a non-infectious corneal ulcer, which is usually located at the periphery of the cornea, and usually the base is clean, there will be no debris and pus formation, you will find some epithelium is covering epithelium is covering the inflammation, so that usually there will be no real staining of the fluorescein and no real ulcer as it is seen in infectious keratitis. You will find mild or no reaction in the anterior chamber, unlike the infectious keratitis. Unless it is associated with systemic disease like rheumatoid arthritis associated with anterior uveitis and so on. So this is your duty. Is very important to determine whether you are dealing with non-infectious keratitis or infectious keratitis. Another thing is important is the grading of your ulcer. Now you should determine whether you are dealing with a mild or moderate or severe corneal ulcer, because this will determine your management, whether you are start using monotherapy or you use a fortified drops, or and how urgent is your case, whether you need to admit the patient to the hospital or not. So generally the classification, if you are dealing with less than 2 millimeter corneal ulcer with less than 20% depth, usually this is superficial infiltration, and usually there is no associated scleral involvement. This is mild ulcer. Now moderate ulcer between 2 to 5 millimeter, and the depth between 20 to 50%. And if it is more than 5 millimeter, it is severe ulcer with infiltration more than 50%, and usually associated with involvement of the sclera. This is regarded as a severe corneal ulcer. Now, in an attempt to have a good clinical approach to your patients, it is advised to determine by the detailed history and the examination whether your patient is following one of these courses. Either your patient has a rapidly progressive disease with suppurative infiltration, or he has a slowly progressive disease with a localized infiltrate. Now, of course, there's exceptions for this rule, but this general plan is very useful in majority of the cases. Just whether your patient has followed one of these courses. Now, if the patient is following the rapidly progressive course with the suppurative infiltration, this is usually due to a highly aggressive bacterial infections like Staphylococcus aureus or Pseudomonas or Streptococcus pneumoniae and Neisseria gonorrhea. And even if the patient was slowly progressing and suddenly becomes actively or rapidly progressing, it indicates a mixed infection or super added bacterial infection. Now, if your patient is already slowly progressing disease with the localized infiltrate, now this is a typical scenario for fungal infection or protozoal infections, or with a bacterial infection with a very low virulence like Staphylococcus epidermidis or alpha hemolytic and streptococci, actinomyces, especially the nocardia and the atypical mycobacterium, and also the moraxilla. Now, this is general approach for your patient so that you can know what type of organisms you are dealing with. Of course, the backup from bacteriological and laboratory investigation will be very useful to support your treatment. Now we come to what's known as organism-specific characteristic. We said before the importance of the history and the clinical examination in helping to identify the causative organism. Although even with expert people, sometimes you face cases that you can difficult correlate the clinical finding with the laboratory finding. And the laboratory investigation becomes an important backup to the clinician to manage the case on solid ground so that he can effectively treat and prevent the complication of such cases. However, there are certain clinical features that help the clinician meanwhile he's waiting for the laboratory result to start his empirical treatment on a solid ground. For example, when you look to the gram-positive organisms or gram-positive cocci, usually they have a well-defined lesion in the cornea and is surrounded by a mild to moderate haze and also mild to moderate anterior chamber reaction based on the virulence of the organism. Now, if you compare this with the gram-negative organisms, when we say gram-negative, especially gram-negative bacilli, the most common is the Pseudomonas, which has a very aggressive course. They have an ill-defined edge, and they have a surrounded with severe haze, so that you cannot determine where is the progressing edge. Is this the progressing edge, or is this the progressing edge? And they have a deep reaction and severe reaction in the anterior chamber. And the reason for this is that the gram-negative bacilli, they produce endotoxins, and these endotoxins penetrates deeply in the cornea and create a severe inflammatory reaction within the cornea. So you will find an ill-defined lesion with severe stromal haze, deep stromal haze. This is suggestive of gram-negative bacilli, commonly the Pseudomonas aeruginosa. Still about the gram-positive cocci, the most common is the Staphylococcus aureus and also the Staphylococcus epidermidis. Now, the Staphylococcus aureus, this is a highly virulent organism and usually affecting a compromised corneas, like patients with bullous keratopathies in which there is corneal edema, and also in patients with chronic herpetic keratitis. And this is very important when you are following a patient with chronic herpes and suddenly he develops a severe corneal abscess. This should be kept in mind that Staphylococcus aureus might be the precipitating etiology. Also, people with dry eye and ocular surface problem. So the characteristic feature is that there will be a well-defined deep stromal abscess with surrounding mild corneal haze, as you can see in this picture. Similarly, now another category of gram-positive organisms, in contrary to the staph, is the strepto. Now the streptococcus is the gram-positive organisms that also commonly can affect the cornea. And the most famous one is the Streptococcus pneumoniae. Now, the Streptococcus pneumoniae is one of the most common corneal ulcers that is usually accompanied by hypopyon, also named as Ulcus cerbens or hypopyon corneal ulcer. When we say hypopyon corneal ulcer, it comes in your mind immediately the Streptococcus pneumoniae. And I would like to remind you here that Streptococcus pneumoniae is the most common causative organism in chronic dacryocystitis. So you should check for these people who have chronic dacryocystitis with corneal pathology. So you should keep in mind the Streptococcus pneumoniae. So the other names for the Streptococcus pneumoniae is Ulcus cerbens or the hypopyon corneal ulcer. Now, why it is named Ulcus cerbens? Because it moves like a serpent, or it means that like a snake, that it has a leading edge. For example, like this, there is a leading edge, and there is the back, there is a healing edge with vascularization in the healing that area. So there is a leading or active infiltration, and there is another edge which is healing. So it is called Ulcus cerbens. Now, it causes a deep infiltration with central ulcerations, and usually associated with severe anterior chamber reaction, which is make the hypopyon, which is usually sterile due to lymphocytic infiltrations. And the reason for that, because the infiltration is very deep to the posterior cornea, so the hypopyon is usually a common feature. And also due to the release of exotoxins from these organisms, so leads to severe reaction with surrounding corneal haze. So that's why it's called ulcus cerbens or serpiginous ulcer. Also, it has a serpiginous spread. Serpiginous spread means like a snake, a rapid spread. So Streptococcus species generally distinguished by their ability to homolyze the red blood cells in the blood agar media. So we have Streptococcus viridans and Streptococcus pneumoniae. They are named as they make partial hemolysis of the RBCs. That's called alpha hemolytics. However, the Streptococcus biogenes causes complete hemolysis of the blood agar, so it's called as beta hemolysis. So this is very important because it is very dangerous, rapidly progressing, and can lead to melting of the cornea and perforations. So similarly, if you can see here, there is a hypopyon, and there is an active edge or serpiginous ulcer, and there is a healing edge in the back. So whenever you find a severe reaction in the anterior chamber with such lesions, you should keep in mind Streptococcus pneumoniae, especially in people with dacryocystitis. If we compare the staph with the strepto here, we will compare the staph species. As I said, that Staphylococcus aureus will make a well-defined intrastromal abscess with minimal haze or no edema around the lesion. And the presence of reaction in the anterior chamber depends on the virulence of the organism and the immunity of the host system. However, if you see the pneumococcus, that's a hypopyon ulcer, characterized by severe inflammatory reactions that associated with severe corneal haze and deep stromal infiltrate and abscess, and also you will find hypopyon in the anterior chamber. So pneumococcus species is known as Ulcus cerbens and cause serpiginous corneal ulcer. And Staphylococcus Staphylococcus species will form a well-defined lesion in the cornea with a clear cornea in the surrounding. Now, another type of streptococcal infection after we finished Streptococcus pneumoniae is what's known as Streptococcus viridans. Now, the special features of Streptococcus viridans that it does not affect normal cornea. However, it usually targeting people with keratoplasty or with abnormal corneas, or people on a prolonged corticosteroid treatment, or people who underwent incisional keratotomy or epikeratophakia, or after chemical burns, or also in contact lens wearers. And it has another name known as infectious crystalline keratopathy because it's characterized by a feathery white opacities in the stroma with minimum inflammatory reaction within the stroma. You will not find hypopyon. And these people, as I said, that commonly they have immunocompromised or they have prolonged use of topical steroids. This is very important question in the postgraduate exam that I will ask you if you have a case of keratoplasty and the patient develops haze and pain in the eye suggestive of keratitis, what causative organism you suspect? It should be Streptococcus viridans, okay? And it is named as infectious crystalline keratopathy. Similarly, this is another picture. Similarly, you have very whitish grayish opacities with minimum reaction in the remaining cornea, and you can see the sutures of the keratoplasty. Now, as far as the gram-negative organisms, the most popular one is the Pseudomonas species. And gram-negative, this is a classical example of a gram-negative bacilli, a very virulent organism characterized by melting of the cornea and with the grayish-yellow abscess formation. Might have a ring infiltrate to the stroma and coalesces centrally and end up by desmatocele and even with perforation, with what's known as ground glass appearance in the periphery of the cornea. Now, if this is a ring infiltrate, the peripheral part will have a ground glass appearance. And this is very fulminant infection, can lead to perforation of the cornea. This is another example. As you can see, severe inflammatory reaction because of the endotoxins with hypopium formations. Also, this is one characterized by the melting of the cornea along with severe mucopurulent discharge. This picture might confuse you with Neisseria gonorrhea, but this is also can happen in Pseudomonas infections, characterized by diffuse melting of the cornea, and sometimes have a ring infiltrate. Now, the ring infiltrate might confuse you with acanthamoeba. However, Pseudomonas is also one of the causes of ring infiltrate to the cornea. This slide shows why Pseudomonas aeruginosa are very resistant to traditional antibiotics. This is owing to the Pseudomonas aeruginosa tend to produce an extracellular matrix that contains collections of Pseudomonas bacteria, and this is known as a biofilm. This biofilm make resistance for the penetration of the antibiotics and allow for further multiplication of the organism and creates antibiotic resistance. This is why nowadays the addition of special nanoparticles known as zinc oxide to some of the traditional antibiotics so that they reduce the resistance of these antibiotics to the Pseudomonas aeruginosa, and also codes against the coding for this extracellular matrix. Now, this extracellular matrix is genetically coded by the messenger RNA from this bacteria, and this will offer extra resistance for these organisms against the antibiotics. So one of these, the job of these nanoparticles like zinc oxide, it prevent or inhibit the encoding for this extracellular matrix and will allow for the penetration of the different antibiotics to this biofilm and provides better response to antibiotics. Now, if we came to the Moraxella, as we have said before, that the general course of the disease can be in the form of a rapidly progressive suppurative inflammations or in the form of a slowly progressive non-suppurative inflammation. Now, Moraxella is a source of bacteria that has slowly growing course and slowly progressive course, but usually it affects a predisposed corneas with edema or bullous keratopathies, or corneas with prolonged use of corticosteroids, or people with recurrent corneal erosions, or all these people are susceptible for Moraxella. They usually have also a well-defined lesions with mild haze, and they have a long course, more than 4 to 6 weeks. You'll find the patient is using treatment and no improvement, so you should think on Moraxella. Now, the reverse for this is the Neisseria gonorrhea. Now, Neisseria gonorrhea usually present as a conjunctivitis, and if you miss the detail, the history, and the presence of sexual contact, so that usually they have a very rapid progressing melting of the cornea, and within 24 to 48 hours, if you don't start treatment, you will find melting of the cornea and even perforation of the cornea. So Neisseria gonorrhea takes the active, very rapidly progressing suppurative inflammations. Now we come to the other typical organisms, which is the nocardia, which belong to the gram-positive filamentous bacteria. Nocardia has a peculiar presentation. First of all, it is indolent infection that's a slowly progressive infiltration of the cornea over a long period of time. Also, it affects the cornea in satellite lesions, multiple elevated satellite lesions, which has a special appearance known as the Riethi pattern. Riethi means a collar that's placed like this on the neck. So you can see that there is a multiple satellite elevated lesions, which forms a collar or a ring around the central part, with usually involves the superficial part of the stroma. And when they get scraped by the spatula, it has a gritty sensation or calcareous sensations that very peculiar to the nocardia. And this form of infection has slowly progressive course, and you can see even make hypopion in the anterior chamber. So this organism should be expected when you have a chronic patient with he used many medication and no improvement. So you should think on nocardia. Now, the other thing that nocardia might also involve the sclera and cause scleritis, especially in people who underwent cataract surgery or due to infection of the plumb after retinal surgery. And it is present as keratoconjunctivitis or keratoscleritis. So that this should be kept in mind, that nocardia is one of the causes of involvement of the scleritis and can cause hemorrhages and severe discharge. The other atypical organism, which is known as mycobacteria. This is atypical mycobacteria or non-tuberculous mycobacterium, characterized by a slowly progressive indolent course with a minimum corneal haze or infiltration. It has a spoke-like projections with central infiltrate to the cornea, sometimes unifocal or multifocal lesions. So that's why it is named as crack window or windshield appearance, crack windshield appearance. So you have a central lesion with spoke-like projections like this. So this is called crack shield appearance. Now, this mycobacterium has a slowly progressive course and commonly seen also in after trauma or after LASIK procedures, especially in the interface. Should be expected and kept in your minds as a causative organism, and should be kept in the differential diagnosis of slowly progressive corneal ulcerations. Now, another important causative organism, which is the Bacillus cereus. Now, this Bacillus cereus is a gram-positive bacilli in comparison to the Pseudomonas aeruginosa, which is a gram-negative bacilli. Although it is not as fulminant as Pseudomonas aeruginosa that lead to corneal melting, the Bacillus cereus will also cause a ring abscess and severe infiltration in the stroma, but usually will not lead to severe melting of the cornea. And usually Bacillus cereus will occur following a trauma, and the feature that the infection will start away from the site of the trauma, and it should be kept in mind for any post-traumatic corneal infections, and should be kept in mind in the differential diagnosis. Now, the importance also of this Bacillus cereus, that it is one of the differential diagnoses of ring abscess formation. As you can see here, there are different organisms can lead to ring abscess formation in the stroma. The most common is Pseudomonas aeruginosa, and then the Bacillus cereus, also acanthamoeba and nocardia, and also fungal corneal ulcers. So we have three bacteria, that's nocardia and Bacillus cereus and Pseudomonas, and we have one protozoan, that's acanthamoeba, and one fungal corneal ulcers. This is very important postgraduate question, that you should know the differential diagnosis of ring abscess or ring stromal infiltrate. Now, there is a new entity of keratitis, which is post-LASIK keratitis, and this happens in the after LASIK surgery, usually in the interface between the flap and the residual stroma. And there are three common incriminated organisms in this type of keratitis, which is the atypical mycobacterium, or the Staphylococcus, or the Pseudomonas, or sometimes multimicrobial. Now, the clinical course will gives you a hint to the underlying causative organism. If the problem starts very rapidly within 3 to 4 days after the LASIK procedures, now Staphylococcus infection should be suspected. If it is a more indolent course, which is start after 10 days, usually think of Corynebacterium organisms as a causative organism. And if it is surrounded with severe edema in the stroma, you should think of Pseudomonas. Now, usually the ideal management for these cases is the use of amikacin for these type of infections, along with the clarithromycin. And also it is mandatory to do a flap amputation. Amputation of the flap is very important to clear these cases, because it might run a very fulminant course, especially in Pseudomonas, and lead to a disastrous outcome. So the management depends on the causative organism, but mainly flap amputation and the use of amikacin is useful in these cases. Now we will say a few words about the post-penetrating keratoplasty keratitis. Of course, we will have a separate lecture about the keratoplasty and all the complication after keratoplasty. But since we are speaking now about the infectious keratitis, so we will say a few words about the post-penetrating keratoplasty keratitis, which is commonly due to gram-positive cocci and seen in around 12% of the cases, 60% within the first year in some studies, and most commonly is due to the sutures. That's why we advise, once you find loose sutures to your patient, better to remove the sutures. There is another special entity of post-penetrating keratoplasty, which is known as the infectious crystalline keratopathy. This infectious crystalline keratopathy, usually the patient has minimum inflammation on prolonged use of steroids for a long time. As you can see here in the surface, projection-like opacities with intact epithelium. And the most common causative organism is due to alpha hemolytic streptococci, and sometimes also due to staphylococci. And of course, you need to stop steroids in these patients and keep them on antibiotic. Another entity which is related to the lamellar keratoplasty, which is due to post-DSEC or anterior lamellar keratoplasty, also known as interface infectious keratitis or sandwich infectious keratitis. And the common causative organism is Candida and Actinomyces, and also sometimes Mycobacterium, Klebsiella, and Staphylococcus. And the most common sources due to from the donor cornea. The transmission most commonly due to the donor cornea. And if you remember, when we speak about the post-LASIK keratoplasty, post-LASIK infectious keratitis, since it is also it has similarity with the lamellar keratoplasty, in post-LASIK the most common causative organism is either Mycobacterium, atypical Mycobacteria, or due to staph or due to Pseudomonas. However, here the most common is Candida and Actinomyces, and also can be also Mycobacteria. Now we will speak about the mandatory laboratory investigation in a case of microbial keratitis and the bacteriological workup that we have to need in a case of infectious keratitis. Now we come to an important issue, which is the bacteriological workup. Now, when you are confronted with a case of bacterial or microbial keratitis, now the usual question that runs in the mind of the clinician, whether to go for detailed bacteriological assessment or just depend on his clinical skills to target the organism using the available antibiotics or any antimicrobial agents. Now, there is some general guidelines based on different studies done, and they came up that you have a minimum requirement for basic bacteriological assessment. After that, you can manage your case. The minimum requirement for minimum bacteriological workup is the use of light microscope with the examination of the corneal scrape with the 10% KOH material. Now, this test is the basic minimum requirement initially, and this helps to rule out fungal and acanthamoeba from bacteria. It has a high specificity of up to 92%. When we say high specificity, it means that we can rule out the disease, but we cannot confirm the disease. So we can rule out the fungal or acanthamoeba infections based just on this simple test. And accordingly, according to the prevalence of infectious keratitis, that bacterial keratitis is the most common. So based on this simple test, you can plan your management initially, especially if there is supported clinical evidence from your clinical examination that gives you clue to the underlying causative organism. The other reason for this that most of the ophthalmologists, they cannot afford to do a high specialized microbiological assessment
especially if they are not working in a tertiary center or a central eye hospital. So just working in outpatient or any secondary or primary healthcare service, this facility may not be feasible because it needs trained doctors and special equipment. So the general guidelines is that after you did your simple scraping and applying the KOH material, and you can differentiate between bacterial and fungal infections. If you have just simple infiltrate or involving the periphery and there is no stromal melting, you need not to do a culture, and you can go directly for empirical treatment that we will speak about it later on. Now, if you have a large infiltrate with central involvement of the cornea with the stromal melting, or with chronic course of the disease with atypical presentation, and there is evidence of sight-threatening complication, at that time you should refer your patient to a tertiary eye center, and you should go for advanced bacteriological evaluation. This is number one. Number two, that there is also some general guidelines for the referral of patient to the hospital. As I said, that advanced bacteriological workup requires a well-equipped laboratory. You need a trained staff, and there is a cost-effective assessment of this procedure. So advanced bacteriological assessment is indicated only in the situation that I have explained before. And also you need to refer your patient to the tertiary eye hospital in the following situations. If you have a severe keratitis which with impending perforation or with real perforation, or if there is any extension that involves the limbus, or if you clinically strongly expect fungal infection based on your clinical background, and if there is a worsening empirical treatment, that's you start with empirical treatment and the situation gets worse, at that time you need to refer your patient to the tertiary eye center. In a single-eyed patient, in a pediatric cases, and in the presence of comorbidity for the adjacent structure like the sclera, or inner structures like endophthalmitis, in these situations you need to refer your patient to the tertiary eye center, and you need to do advanced bacteriological assessment. Otherwise, if you have confronted with a simple case, as I said, with peripheral lesions, and there is no significant corneal haze, you can start after KOH treatment with your empirical treatment after you rule out fungal infection. But if the result of the KOH test reveals fungal infection, this is also an indication to refer your patient to the central or tertiary eye center. In this slide, I will show the different steps or the examples of the advanced bacteriological assessment that you need to follow in a tertiary center when you have the indication for this, as I said, when the presence of expected fungal infections, or a single-eyed patient, or a pediatric case, or impending perforations, or no improvement to the empirical treatment. So you need to do a smear for your case, as well as culture. As you know, the smear should be stained with the gram stainings to determine whether there is a gram positive or gram negative organisms, and the KOH for ruling out fungal or acanthamoeba infections. And the culture, we have a set of cultures for as a solid media or a transport or a liquid media. Also, we can do the PCR, which is very useful and helpful, especially in viral keratitis. The different solid medias, as you know, the blood agar, the chocolate agar, and the non-nutrient agar for acanthamoeba. Also the saboroids dextrose agar for fungal infections, and the potato dextrose agar, and the liquid medias or the transfer media like the thioglycate agar and brain and heart infusion broth. So these are the advanced bacteriological assessment that you need to do for your case. And also you can do some physical assessment, like the use of OCT will be very helpful also in determine the degree of infiltration within the cornea, and if there is any adhesion between the anterior chamber exudates and the cornea, it will be visible by the OCT. So as I said, that this is indicated in a special situation that I have explained, keeping in your mind that treatment with antifungal and anti-acanthamoeba drugs must be started only after the organism have been documented. So it is preferably that you document the presence of acanthamoeba or fungal infection to start such type of treatment, And in the presence of severe keratitis, treatment must be at a tertiary center after advanced bacteriological assessment. Now, as far as the bacteriological assessment of the corneal infection, it is done mainly by taking the sample using the scraping of the cornea. The scraping can be done with use of special blunt spatula known as the Kumara spatula, or the use of 15-degree blades which has blunt end. Also, some people they use the bent tip of 20 gauge hypodermic needle or 11-degree blades, which is a little bit sharp, which carries the risk of perforation. For me, I used to use the 15-degree blades, which is very safe and blunt, to take the scrape and the sample, and then you can inoculate it to the slide. Use the KOH media, as I said, or the gram staining, so that you determine whether it is gram positive or negative, and the KOH to determine whether it is bacterial or fungal. And for further detailed, more investigation you need, you can use special media, that's the blood agar media, the chocolate agar media, the non-nutrient agar media for acanthamoeba, or also special media you can use for atypical mycobacteria, and also some transport media for viral infections. Of course, this need a very good collaboration with the bacteriological department, so that you can reach to a good support based on the clinical finding. You can have a very good laboratory support. Another important points while we are speaking about the microbial investigation, that aqueous tape and vitreous tape should not be performed in these cases because of the risk for intraocular inoculations of the organism. So unless it is highly suspicious microbial endophthalmitis is there, it is better to avoid to do any vitreous tape or aqueous tape. Another thing, that in case that you did a culture and it came negative, what's the indication for repeating the culture? Now, if you have a lack of favorable clinical response after your initial result, for example, sometimes the result is misleading, so you start your treatment and you still note that worsening of your patient, so you need to do repeating for your culture and sensitivity. Also, toxicity from medication or corticosteroids withdrawal may be confused with antibiotic failure. So sometimes because these patients, they will have poly medications, and sometimes they have a prior use of steroids before they came to you, so the reaction is limited. However, once you stop the steroid, so the picture will flare up sometimes, and also the patient will exhibit some signs of toxicity of the cornea because of the poly medications. So in these cases, better if you have worsening of your case, better to stop all your medications at least for 24 to 48 hours, and you repeat your culture again, and you accordingly you restart your treatment. So this is very important to keep this in your mind, that avoid vitreous tape or aqueous tape in the case of suspected infectious keratitis, and you should monitor the response of your patient to your treatment after the result of your culture. If there is worsening of the situation or there is no improvement, you have to stop your treatment and take another culture and repeat your treatment again. Among the new indication that necessitate an urgent and immediate detailed bacteriological investigation when you first get confronted with such cases is, for example, in post-LASIK infectious keratitis, as this is very urgent and should be dealt in a very quick manner. Also, in the cases of post-cataract infections, especially infections of the tunnel, when there is suspicious of infection of the tunnel, because this can lead to endophthalmitis. And of course, the contact lens wearers, when there is a contact lens wearers with ring-like infiltrate in the cornea, we should send the contact lens along with the contact lens solutions and the cornea scrapes immediately for detailed bacteriological assessment. And of course, in pediatric cases, as I said before, all pediatric corneal keratitis should be dealt in a specialized center with a specialized people and in advanced laboratory microbiological lab. Also, in hospital-acquired infections should be dealt in a special centers. And finally, in a non-responding corneal ulcer, after you start your empirical treatment and there is no response, now you should do a holiday for your treatment and then repeat the scraping and send the case to a specialized center. Now, the new thing that we have to discuss is what about the role of corneal biopsy? What are the indications? What are the advantages of corneal biopsy? And what are the precautions that we should do corneal biopsy? Now we come to an important way of microbiological examination is the use of corneal biopsy. Now there are certain indications for corneal biopsy, especially after recurrent negative corneal scraping and we have indolent ulcer that is slowly progressing. So in these situations we need to do corneal biopsy rather than corneal scraping. Also, as I said, the presence of negative result on repeated scraping when you have a deep-seated corneal infiltrate which is not amenable for corneal scraping, so you need to remove the superficial part of the cornea to gain access to the deeper part. When there is suspicious of microbial infections, and when there is fastidious or slowly growing organisms like Mycobacterium or Nocardia. The advantage of corneal biopsy over corneal scraping is that the corneal biopsy affords more diagnostic materials, and there will be a possibility to increase the sensitivity of the culture because we will send the sample for both, for histopathological examination as well as for microbiological culture examination. So it offers extra power or extra tool to identify the organism. As I said, histopathological examination can be done along with the corneal biopsy, including electron microscopy and immunohistochemistry, especially in viral infection. But there are certain precautions that you should keep in mind before you do the corneal biopsy, that you should give a holiday treatment for 24 to 48 hours before the biopsy, and you should avoid installing betadine prior to the biopsy because this will affect the culture. This is a picture of some of the instruments that we need for the corneal biopsy. The most important one is the punched trephine. We don't use the suction trephine, we use a punched trephine along with a diamond knife to do lamellar dissection or trephination of the corneal biopsy. We should avoid the visual eggs, and we should have at least 1 millimeter from the normal cornea in advancing edge of the corneal ulcer. And as I said, we should send the sample for both for microbiological culture assessment as well as for histopathological examination. Now, apart from the microbiological investigation, we shouldn't forget the important tool, which is the confocal microscopy, which utilizes in vivo visualization of the causative organism within the cornea. And although in many centers it is just for research purpose, but in some specialized center it is used in a clinical practice. The indication for confocal microscopy for deep-seated corneal infections and indolent infection that is not responsive to the traditional treatment, like acanthamoeba or fungal keratitis or microsporidia, and also to assess the response to treatment when you compare the picture before treatment and after treatment. Another molecular diagnostic technique, which is the polymerase chain reaction, abbreviated as PCR, one of the most sensitive existing rapid method to detect the microbial pathogens in clinical specimens, and it adds an important or diagnostic value for the assessment of the pathogens that are difficult to culture in vitro, and it requires cultivation such as the acanthamoeba and also in Mycobacterium or atypical Mycobacteria, and also it has a major role in the herpetic infections, especially the herpes simplex virus. PCR stands for polymerase chain reaction, depends on the amplification of the DNA for the organism, and can detect the causative organism. Now, among the recent areas of advancement in the detection of the causative organism in infectious keratitis is the utilization of the molecular diagnostic tests. The molecular diagnostic tests, namely the PCR, which stands for polymerase chain reaction, and the new generations that occurs especially after the era of corona and the advancement in the technology of the PCR, make it very feasible to accurately determine the causative organism based on the amplification of the DNA segments of the causative organism. So the same principle, it depends on the detection of the nucleic acids in the sample, and especially useful in where there is fastidious organisms that's difficult to grow in culture. So by just determining the DNA from that sample is enough to determine the causative organism. And it is more sensitive than the culture. Of course, it is more sensitive than the culture because the culture can be contaminated with multibacterial or multimicrobial growth, and also the commensal organisms. So it might be difficult to determine the causative organism. And also it is useful for rapid detection of the causative organism. And even when the presence of very minimum samples, it will be enough for the PCR to determine the causative organism. It is extremely sensitive, and when we say sensitive, it means that the chance of false positive will be high, and also extremely specific, and in this time the false negative will be high. So you should carefully read the result of the test so that you avoid the false positive and the false negative results. Now, the steps of the PCR generally, or the sequencing of the PCR based on the amplification and sequence detection of the DNA from the sample. Then there will be 3 steps. That's the denaturation of the proteins of the sample, then hybridization, and I'll explain in the next slide the meaning of hybridization, and then elongation of the segment and amplification of the segment so that can be determined the causative organism. As I said before, that the era of corona make the researchers and the companies to concentrate on the PCR as a diagnostic tools. So the standard PCR, mainly you have the uniplex, which has 1 round, and the nested one, which has increasing sensitivity but a high risk of contamination. Now, this is, as I said, that is extremely sensitive with a chance of false positive, and extremely sensitive specific with the chance for false negative, and it is useful to determine the minimum DNA present in the sample to determine the causative organism. But the disadvantage that it cannot differentiate between active and latent infections, and between viable and non-viable segments, because you will find the DNA segment but you don't know is it viable or not viable, and also whether there is active infection or it is a latent infection. That's why the new trend in the PCR, which is known as the real-time PCR, the DNA copy from the bacteria, especially the ribosomal DNA, which is very specific to the bacteria. We have 16 segments of the ribosomal RNA, and also for the fungi, so precisely can determine the causative organism, and it has advantage over the standard PCR that can differentiate between latent and active infections, and it has less contamination. Now, another area of recent advances in the bacteriological assessment in cases of infectious keratitis is the use of the what's known as the nucleic acid hybridization in the assessment of the samples or the specimen taken from the cornea, based on the idea that try to find out the single-stranded DNA or RNA from the organism, and make a hydrogen bond with this DNA to determine the causative organism. This process is called as nucleic acid hybridization. Best examples is the use of southern blot and the fish, which is the fluorescent in situ hybridization. Now, I will speak about this fish in the next slides. However, the principles of nucleic acid hybridization, for example, if you have a known sample of DNA segment named as A, and you have unknown DNA segment from a species known as B. So by heating, the double-stranded DNA will be converted to a single-strand DNA. Then each one in the test tube, we add, for example, the known sample of the DNA segment to the unknown sample of the DNA segment. If there was a complete identical hybridization between the DNA segments, so this means that the organism is identified and is identical to the known segment of the DNA. And if there is partial hybridization, so there will be, the species will be related to that organism, but not 100% identical. And if there is no any hybridization between the two segments, so this indicates that the organism is unrelated. This process is called as a nucleic acid hybridization. It is very useful in determining and specific in determining the causative organism. Now, as far as the fish technology, which is the fluorescent in situ hybridization, utilizes the same principle of the nucleic acid hybridization and uses what's known as the genoprobe. There is a special probe with direct labeled with the nucleic acid and is usually tagged with the fluorescent material or luminescent material, so that when this probe is attached to the DNA of the sample, so based on the result, there will be identification of the causative organism by this process, by identifying the ribosomal RNA from the species, especially the bacteria, which is specific for each type of bacteria. So when there is coupling between the different segments of the nucleic acid between the single-stranded DNA and RNA, so the organism can be identified. This is known as FISH technology or fluorescent in situ hybridization, very specific and very accurate in assessing or identifying the causative organism. Now, in the next coming slides, I will speak about the recent advances in the bacteriological evaluation in a patient with infectious keratitis and the future of the diagnosis using alternative strategies, mainly the new generation of sequencing and the PCR, which is, as I said, the real-time PCR now is very useful in determining the difference between active infections and non-active infections. Also, the use of smart probes, which are special probes, are polypeptide probes that link it with a single-stranded DNA or RNA, and also labeled with immunofluorescent substance. And it can determine the sequence of nucleic acid sequence of the causative organism, and quickly can determine the most probable organism. Also, we cannot forget about the usefulness of artificial intelligence, which is newly emerging now after the doctor doing the gram staining and using the slides in the microscope, utilizing the artificial intelligence to determine the most probable causative organism. Another area of emerging, which is known as the proteomics, the personalized medicine, that it utilizes the biomarkers, the host biomarkers, which determines the cellular and the tissue proteins, as well as the fluids proteins in the tears film, for example, to determine the causative organism and what are abnormalities going on. This is called proteomics and genomics. The genomics is determine the defect in the genes, and the proteomics is determine the abnormalities in the proteins. And based on the proteomics, they can determine the causative organism. We will explain about this in the next slides. Now, the newly emerging science, which is the science of proteomics, is newly emerging based on our understanding of the mechanism of formation of the tissue proteins and the cellular proteins from the transcription of the single human genomes, and plenty of proteins are formed as a single strand or as a polypeptide, as a sheet or as a helical that end up with the formation of proteins. Now, our understanding of the mechanism of transcription from the double-stranded DNA and transcribed to a messenger RNA, and this messenger RNA will be translated finally to the proteins, and this protein will be undergo further modification to form polypeptides and sheets. Now, our understanding of this lead to the creation of the science of proteomics, that we can determine some biomarkers can gives an idea about the cause of organism of the infectious keratitis. And this was made by the use of mass spectrometry, which is known as the mass spectrometry. This is the backbone for the proteomics, that based on this, the sample is placed in this machine and can determine the biomarkers that refers to the particular causative organism. Now, when we speak about the management of infectious keratitis, this is a very long journey, start from the history taking and end up by the visual rehabilitation. Now, you should keep in your mind that the corneal infections, it might be a simple infection that you can control it easily with just a few drops for 5 or 7 days, and it can end up by a devastating complications with a perforation or dysmetocele and endophthalmitis, and end up by losing of the eye. So you should have a systematic step-by-step procedure in the management of your case. As I said, start with the detailed history, including history of trauma, history of using contact lenses, history of use of any topical antibiotic or steroid drops, history of immune suppressions, history of smoking, and history of systemic diseases. All of these are very important to assess your patient properly and determine what could be the underlying cause. Also, history of any surgical intervention like keratoplasty or any procedures that's done in the eye that make the eye more vulnerable to the infection, because it is very important to determine the precipitating factor. As we have said before, that the precipitating factor, there must be a precipitating factor for your corneal infection. Now, the clinical examination also plays an important role in the management. The clinical examination includes two aspects. Number one, try to determine what are the clinical findings in the corneal pathology, so that can gives you a clue to the underlying causative organism. The presence of hypopyon, the presence of associated conjunctivitis or scleritis, the presence of associated glaucoma, and so on. Also, the location of the lesion, whether it is central or peripheral, near to the limbus, or it is away from the limbus. Is it superficial or deep? Is it suppurative or non-suppurative? All these are very important that guide your management. Another thing or another aspect of your clinical examination is to determine any coexisting pathology. For example, the presence of chronic dacryocystitis, or presence of entropion or ectropion, or maldirected lashes, or the presence of ocular surface of problems. All these are very important. Now, as far as the laboratory investigation, this is a very adjunctive power that you use to determine the causative organism. Now, for the laboratory investigation, you need not to start with a sophisticated advanced bacteriological assessment, as the general guidelines from the American Academy that you need at least to do scraping of your cornea, and you stain with KOH staining to determine whether the underlying causative organism is bacterial or fungal. Now, once you determine whether it is bacterial or fungal, you need to use either a gram staining or GIMSA staining to determine whether it is gram positive or gram negative. Now, after these two steps, you can start your empirical treatment based on the initial result of your laboratory investigation, so that you can use antibiotic or antifungal according to the initial result. Now, the need for advanced bacteriological assessment is kept for selected cases in which there is advanced inflammation of the cornea with impending complications, or there is no response to your initial treatment, or in a patient who's immunocompromised. Now, in these situations, you need to do a detailed laboratory investigation with the inoculation to different media, and use even viral transport media, and use detailed fungal media, and so on. But as a generally, for more than 80% of the cases, what you need is just to start your scraping and stain with KOH staining to determine whether it is bacterial or fungal. And then you do the gram staining and the GIMSA staining to determine whether it is a gram positive or a gram negative. Now, the treatment is dependent on the initial result of your laboratory investigation. If you decide to use a monotherapy or combined therapy, that's fortified drops, you need mainly to use topical drops, topical frequent drops. Now, the question here of the use of the systemic antibiotic also is not needed in most of the cases. The indication of use of systemic drops only when the lesion is near to the limbus or invading to the sclera, or when there is a perforation with evidence of endophthalmitis. At that time, you need to use a systemic antibiotics. However, they found that most of the cases, just topical frequent drops is needed, as the penetration of the cornea is enhanced when there is a removal of the epithelium. So you can reach to a therapeutic level of intracorneal concentration of the drug just with topical drops or with fortified drops. Some people also advocate the use of intrastromal antibiotic injection, but this is also a controversial because you need to have a frequent drops because the shelf life for these injections is within 24 or 72 hours. So you need to have frequent injections, and sometimes the cornea is friable and the risk of perforation is there. So and you need to have multiple injections to surround the infections. So some people, they don't advocate the use of intrastromal injections, especially they found that it is not superior for frequent recurrent drops inside the eye. So this is a matter of controversy. Now, another aspect of the management is the follow-up. Now, the follow-up is very important here because based on the initial 72 hours after your initial treatment, you can assess your patient whether he has some improvement, at least in the symptoms. Improvement carries two aspects: improvement in the symptoms of the patients and improvement in the clinical finding. Now, if you find your patient has a significant improvement, at that time you will continue with your treatment, and you might add some adjunctive treatment, as you will see later, the use of cycloplegic drugs, the use of anti-glaucoma drugs, the use of analgesic drugs, and so on. Also, if there is no improvement, you can decide to add another treatment, or you can revise your laboratory investigation and accordingly. Now, the last thing is the visual rehabilitation. Now, after you manage your patient and the infection and the dangerous stage has been bypassed, and the patient ends up by residual or sequelae of this problem, which is the corneal opacity and the reduction of the vision. Now you need to do some rehabilitation for your patient to improve his vision. And of course, during this journey, you need to sometimes to admit your patient if necessary, especially if the compliance of the patient is not guaranteed, or if the patient is living in a far place and he cannot come to you. At that time, you need to admit your patient. Also, if the patient has a high predisposing factors, you need also to remove the contact lens during the management, and you need to send the contact lens to the lab for assessment, for the bacteriological assessment. And also you have to manage meanwhile the ocular surface problem and the immune suppression that the patient has suffers. Now, another advice, since the patient using many drops and the issue of epithelial toxicity is on the table, and this will retard the healing of the epithelium, better and advisable not to use multi-drug therapy unless necessary. For example, if you want to use anti-glaucoma treatment, better advised to use oral anti-glaucoma treatment rather than topical anti-glaucoma treatment in a patient with secondary glaucoma, so that you minimize the toxicity of the epithelium, so that you will enhance the epithelial healing. This is very important. Another thing that you can use different other ways of enhancing the drug concentration within the cornea, like the use of bandage contact lenses or the collagen shields to improve the concentration and increase the contact time between the drug and the cornea, so that you increase the concentration. Some people, they advocate the use of subconjunctival injections, and this also under debate and investigation. Before, we used to use for every and each patient with corneal infections, we use subconjunctival injections. But now they say that, as I said, the frequent topical drops is enough to maintain a therapeutic level of the drug concentration within the cornea, and then no need to hassle the patient with many injections and painful injections under the conjunctiva. Another aspect is the patching of the eye. There is no rule for patching of the eye in infectious keratitis. It is advised not to cover the eye, as we used to do before many years back, that whenever there is any ulceration in the cornea, we keep patching of the eye. Now there is no rule for patching the eye. In contrary, the patching of the eye will increase the temperature, and this will increase the proliferation of the organism. So better to keep the eye open, because this will expose the eye to the air and also to the aeration of the cornea, and also prevent the multiplication and the proliferation of the organism. This is the general guidelines for the management of infectious keratitis. Of course, there is a specific management for each specific causative organism. We will discuss this in details. For example, in fungal keratitis, there is special measures. in viral keratitis, in bacterial keratitis, and so on. But this is a general guidelines for the management. Now, after finishing the history taking and examination, there are certain clues at the presentation that make the surgeon or the doctor utilizes the art of etiological diagnosis based on the clinical examination. There are points in favor of bacterial infections. For example, the presence of ocular surface disease is in favor of bacterial infections. When the course is very rapid course, usually gram-negative should be suspected, and the gram-negative is more faster in the course as compared to gram-positive bacteria. Also, the presence of wet corneal ulcers and necrosis with yellow exudates and epithelial defect with discharge or associated conjunctivitis, all these points are in favor of bacterial infections. Also, the presence of severe AC reaction and hypopyon. Also, the symptoms usually respond rapidly once we start the treatment, and it has a short course. This is all in favor of bacterial infections. In comparison to the fungal infections, which commonly preceded by trauma by organic objects, and the history prolonged use of steroids usually has indolent and chronic slowly progressive course with the presence of dry and white ulcer. The cornea, you will find it loose of luster and dry, and the presence of like hyphae in the surface of the cornea. Also, the presence of pigmentation on the surface of the cornea, and on corneal scraping, the presence of gritty sensations, and also the presence of exudates or hypopyon that is not moving with the head movement or the eye movement. All these are in favor of fungal infections. Multiple corneal satellite lesions, and you will find the signs more than the symptoms, that you find severe signs in the cornea with minimum symptoms from the patients, and upon treatment they very slowly respond to the treatment. All this are in favor of fungal keratitis. Now we will start with the use of antibiotic in the treatment of microbial keratitis. After we have taken detailed history and doing detailed examination of the patients, and of course after doing the basic preliminary bacteriological or microbiological investigation in the form of KOH and gram staining and GIMSA staining, at least you can determine that you are dealing with a bacterial infection, not a fungal infection. At that time, the recommendation based on the American Academy that use either a monotherapy or combination therapy. The guidelines is that for an initial treatment with a lesion of less than 2 millimeter infiltrate, that we use fluoroquinolone as empirical treatment while we are waiting the result from the lab. We use it as empirical initial therapy because it is a broad spectrum antibiotics, and some they advocate what's known as the rule of two. That's if you have a lesion of less than 2 millimeter diameter with a minimum AC reaction less than 2 plus cells within the anterior chamber and away from the visual axis by more than 2 millimeter, this is an indication for monotherapy using the fourth generation fluoroquinolones. Now, the fourth generations is very important. Examples are the bestifloxacin, getafloxacin, and monofloxacin, and should be used in a loading dose for what's known as the sterilization phase. I will explain it in the next slide. The loading dose between 5 to 15 minutes for the first hour, then hourly for the next 48 hours, and then you can make it 8 times a day for at least 7 to 10 days till you have signs of clinical improvement. Like, for example, if you have decreased pain, especially which occur within the first 24 hours, you have decrease in the discharge, consolidation and demarcation of the infiltrate, decrease the density of the lesion, less edema, and decrease of the anterior chamber reaction and the hypopyon, and you have signs of reepithelialization. All these are signs of improvement, and at that time you can stop the drug. Now, the drug should be stopped abruptly, not gradually, because gradually will lead to development of drug resistance, and should be stopped abruptly. Now, another thing, the dosing is very important, at least 8 times per day after the first 48 hours. Unlike in the prophylaxis in cataract cases that we use it 4 times a day, but in infectious keratitis should be used 8 times per day. So the treatment regime, as I said, that we have two phases. We have the sterilization phase, and then we have the healing phase. Now, for the sterilization phase, as I said, that we have to use a loading dose of the fourth generation quinolones. That's every 5 to 15 minutes for the first hour, followed by hourly for 48 hours. Then we can decrease the dose a little bit till you have signs of improvement. Up to 2 weeks you can use it, and when you see the signs of improvement you can stop the drug abruptly. Now, if the infiltrate is more than 2 millimeter with more than 2 plus reaction in the anterior chamber that involving the visual eggs, this is regarded as a moderate ulcer, and these cases preferably we do a combination therapy. Combination therapy basically dependent on cephalosporins, namely the cefazolin 5%, adding to it either atobromycin 1.3% or ciprofloxacin 0.3%. As you know, the cephalosporins mainly active against gram-positive cocci and aminoglycosides against gram-negative bacilli. Now, how we prepare the fortified drops, as I explained before, the cefazolin or ceftazidime, the usual dose is 50 milligram per ml, and we add 10 ml of the artificial tears or the water for injection, as except unless we prefer to use the water for injection, as I explained before, because of the osmolarity, but also you can use the artificial tears. And we add the 10 ml in 1 gram vial of the cefazolin, and then take 5 ml from this extract and add another 5 ml of artificial tears. Of course, the shelf life is very short, should be kept in the refrigerator and should be shaken before use. Similarly, for aminoglycosides, the dose is for 14 milligram per ml. We have to use the 2 ml injection vial, which contains 40 milligram per ml, and we add to this 2 ml 5 ml of the solution to receive a 14 milligram per ml solution. Now, for the vancomycin, we have different concentrations. We can have 15 milligram ml, or we have the 25 milligram per ml, or we can have the 50 milligram per ml, and diluted in the normal saline according to what you are seeing now. If you add 33 ml, you will receive the 15 milligram ml to the vial that contains 500 milligram of vancomycin. If you add the 20 ml, you will receive 25 milligram per ml. If you add just 10 ml, you will receive 50 milligram per ml. If you use the amikomycin IV injection that contains the 80 milligram per 2 ml, you can adjust the dose as I mentioned here. Also, you can use the trimethoprim or sulfamethoxazole. The dose is 16 milligram per ml for trimethoprim and 80 milligram per ml for sulfamethoxazole. This is how we prepare the fortified drops. As I said, the risk of toxicity is there, so you should stick to these levels and should not be used more than 1 week. And if there is any discoloration of the preparation, better to be discarded and should be shaken properly before use, and you should keep it in the refrigerator. In this slide, I will speak about how we prepare the fortified drops, namely the cephalosporin, either the cefazolin or ceftazidime. The usual dose is 50 milligram per ml, that's 5%. So how we prepare it, we have two ways. Either we prepare it using the artificial tears or using the water for injection as a diluent for this preparation. Now, if you have a 10 ml artificial tears bottle, we place it in a vial of 1 gram of the powder injection for cefazolin, and this make the concentration of around 100 milligram per 1 ml. Then if we take 5 ml and then we add another 5 ml of artificial tears, so the final concentration will be 50 milligram per ml. Of course, this will have a short shelf life and should be refrigerated and shaken before installations. Now, the same thing if we use the water for injections, we use the ampoules for 250 milligram of cefazolin, and we add 5 ml of the water for injections, and we put it in the refrigerator and should be discarded if there is any discoloration of the preparations, or if it is more than 1 week. The shelf life should not be more than 1 week. Now, what's the difference between artificial tears as a diluent or as a normal saline? Investigation showed that the osmolarity using the water for injection, the osmolarity will be near to normal. That's around 450 milliosmoles. However, if you use the artificial tears, the osmolarity of the preparation would be around 780 milliosmoles, which is too high for the cornea. And this will give the patient a gritty sensation and burning sensations, and also retard the absorption of the drug a little bit to the cornea. So it is advised better to do the preparation in water for injection rather than artificial tears. This is the message that I would like to convey to you. Now, if we look to the advantage of use of fluoroquinolones as monotherapy, fluoroquinolones are commercially available in the market and over the counter, and they have the problem of shelf life is not an issue because they are already with preservatives. Also, the issue of the pH and tonicity is not a problem, and they are not toxic even if used for long time. However, when we look to the combination therapy, I mean the fortified antibiotics, they are not available in the market, so you need to prepare them yourself, and they have a limited shelf life. As I said, should not be used more than 1 week. And now the issue of pH, tonicity, and osmolarity is very important because you have to know and use the proper diluent, either the artificial tears or the water for injection for preparation, and they are toxic when used for long time. Now, this table shows the common antibiotic used against common causative organisms. For empirical treatment, as I said, that you can use the fluoroquinolones as a monotherapy, or you can use the combination therapy. And based on the concentration, the range, the spectrum of this organisms based on the concentration. Now, if the result came to be gram-positive cocci, better to use the cephalosporins or the vancomycins or the teicoplanin. And for gram-negative rods, you can use the fortified aminoglycosides or fluoroquinolones or ceftazidime. Gram-negative bacilli, especially the Pseudomonas, you can use the fluoroquinolones, the 4th generation, along with the cephalosporins. And for Mycobacterium and nocardia, now this is important. You must use amikacin or clarithromycin for Mycobacterium and nocardia. That's why the bacteriological examination is very important.
Just a few words about the fluoroquinolones that we commonly use in infectious keratitis. The fluoroquinolones was initially derivatives of nalidixic acid, and when it was fluorinated, it is named as fluoroquinolones. And usually they use the suffix floxacin to refers to the fluoroquinolones, like ciprofloxacin, levofloxacins, and moxifloxacin, and so on. Now, the fluoroquinolones, they have different generations, like the ciprofloxacin, which is the 2nd generations, and the levofloxacin, the 3rd generations, and the moxifloxacin, that's the 4th generations. They have mainly activity against gram-negative organisms and some of the gram-positive organisms, and mainly on aerobes. And as they progress from the 2nd generation to the 3rd generation, and then the 4th generation, that's the moxifloxacin, it extends the range to involve a large range of gram-positive organisms and even anaerobic organisms. So the progression from the under generation to the higher generations maintains the previous activity and adds more spectrum for its activity. So this fluoroquinolone is very important drug in the monotherapy for infectious keratitis. As far as the spectrum of action of the quinolones, as I said before, they have spectrum against gram-negative organisms, mainly gram-negative bacilli, and also they have also activity against gram-positive organisms and methicillin-sensitive Staphylococcus aureus, and also, as I said, gram-negative bacilli and cocci, and also they have activity against Pseudomonas, especially ciprofloxacin, and they have no activity against anaerobes except the 4th generation, which is the moxifloxacin. So the 1st and 2nd and 3rd generations, they have no activity against anaerobes, as I said before, except moxifloxacin, which is the 4th generation that has activity against the anaerobes.
Now, the mechanism of action is mainly a bactericidal because it inhibits or interferes with the DNA synthesis by inhibiting two main enzymes, that's DNA gyrase in gram-negative organisms and topoisomerase 4 in gram-positive organisms that prevent the unheliking of the DNA, and this is an important step in the DNA synthesis, so it is mainly a bactericidal. Now, the problem of quinolones that there is growing on emerging resistance to quinolones because the organisms learn how to protect themselves and pump out the quinolones from the DNA. So each time there will be increasing resistance to quinolones. So this is the main mechanism of action of quinolones. And as I said, it is one of the major drugs that use it in the monotherapy in infectious keratitis. As far as the fluoroquinolones, the problem of fluoroquinolones, the emergence of drug resistance is very rapid. For example, you can see here the emergence of drug resistance for Staphylococcus aureus over a period of many years in treating keratitis and endophthalmitis and conjunctivitis and blepharitis, so that you should use recent generations of fluoroquinolones, like the fourth generation fluoroquinolones, and you should take scrap from your cornea and make sure that your organism is sensitive to what antibiotic you are using for. So you should keep in mind this. The other thing that when you use fluoroquinolones, you should use the proper dose and avoid gradual tapering, because the tapering of fluoroquinolones, this will lead to emergence of a drug resistance. It should be stopped abruptly once you find clinical documentation of healing of the ulcer. So this is very important. You should keep it in your mind that if your patient is not responding, you should think of emergence of drug resistance. Another important antibiotics which is also used in infectious keratitis, namely the aminoglycosides, the gentamicin and the tobramycins, they have a bactericidal effect against aerobic and facultative gram-negative bacilli. However, when we say gram-negative bacilli, we mean mainly the Pseudomonas. However, the emergence of resistance of Pseudomonas to the aminoglycosides make the need for use other antibiotics in combination with these drugs to overcome the resistance of Pseudomonas. And in severe cases, as I said, usually combined the aminoglycosides with cephalosporins to cover the range of gram-negative bacilli. Now, the other antibiotic, which is the macrolides, they are large proteins that inhibit the protein synthesis of the bacteria. They have a bacteriostatic effect, and namely the erythromycin, azithromycin, clarithromycin, and rosectomycin. They have a range against gram-positive and to some extent gram-negative bacteria. But the problem of their large molecules and poor solubility through the cornea make the future use of these antibiotics in infectious keratitis of a limited use. Now, the other important drugs, which is the cephalosporins, we have the first generation cephalosporins like the ceftazidime, which has range against gram-positive pathogens, and it has a minimum toxicity when used topically, usually used in combination with other gram-negative organisms, other antibiotic used against the gram-negative organisms, mainly the aminoglycosides, to extend the range and becomes a broad spectrum. The third generation, which is the ceftazidime, which has an anti-Pseudomonas activity, usually kept for cases which is resistant to the aminoglycosides, as I said before. So ceftazidime is a very good drug, especially in Pseudomonas resistance cases, and used in combination with aminoglycosides. It has both a range against the gram-positive and also gram-negative bacilli, that's the Pseudomonas. Now, the last drug, which is the glycopeptides, namely the vancomycin. This vancomycin has an advantage of the activity against penicillin-resistant staphylococcus, especially the MRSA, that's the methicillin-resistant organisms, and it has its effect by the inhibition of the biosynthesis of glycoproteins within the cell wall of the organism, and it should remain one of the most potent antibiotic against MRSA and coagulase-negative staphylococci. And that's why the vancomycin should not be used in any case, should be reserved for cephalosporin-resistant organisms to avoid the occurrence of any drug resistance. Again, this is a flow chart showing how to deal with the case once you get confronted with the case. So you will start with taking the corneal scraping and do gram staining, the KOH staining, and immediately send to the lab and see whether it is fungal or bacterial. Then you'll start your empirical treatment if it is bacterial. And then once the result from the lab comes, and you have bacteriological background, at that time you can modify your therapy based on the smear that you have done. After that, you need to monitor your response for at least 7 days and see if there is any signs of improvement. If there is any signs of improvement, as we explained before, you will continue with your medication till full epithelialization takes place and make sure that there is no more any evidence of active inflammations. If not, you have to do stop your medication and take another scrap and make sure that you are treating the real causative organism. Now, if we enumerate the causes of non-responding corneal ulceration that you are dealing with a patient and there is no response or even maybe a worsening of your ulceration or the infections. So there are different reasons. You might, there is no response to your treatment, or there is non-resolving ulceration with worsening of your infection, or you are dealing with a non-infectious ulcerations like ocular surface disease or dryness, or you are dealing with immune-mediated ulceration, not infectious ulcer, like Morin's ulcers, or there are sometimes multifactorial combinations like neurotrophic ulcers with ocular surface problem and so on. Now, if your ulcer is not resolving or even deteriorating, so you should revise the following points. Maybe you have a wrong line of treatments, so that you are treating fungus, which is a bacterial infection, or you are treating with antibacterial, but it is a fungal infections, or there is very rare or unusual infections, or you have a drug resistance, or there is a high infection load. This is very important. When you have very high infection load, what's known as the biofilm, sometimes the organism will be aggregated in a matrix that adhere to the surface of the cornea in a form of a biofilm. This biofilm will form a high load as well as high resistance to your medications, and also will lead to poor drug penetrations. Also poor compliance of the patient, that he is not using the medication properly, or sometimes because of polymedications there might be keratitis medicamentosa, that's due to epithelial toxicity, and this will retard the healing of the epithelium. Also, there are some ocular surface problems and immune-mediated problems that retard or prevent the healing of the corneal pathology, or you have comorbidity or associated systemic diseases like rheumatoid arthritis. So you have to revise your diagnosis and you check what could be the cause for non-responding corneal ulcerations. Now we come to an important subject, which is the use of corticosteroid therapy along with antimicrobial therapy in the treatment of infectious keratitis. This subject is not a new subject. It has been exposed to a large debate since 1960s. And by the emergence of the first drops, which has combination of antibiotic with the steroids. And this debate between two groups, the first group that support the use of steroids, they claim that part of the damage that happens to the cornea and part of the fibrosis that happens in the cornea is related to the host immune system. And since steroids act as anti-inflammatory and it will reduce the host immune system, so this will reduce the corneal scarring. The other group in the debate, they are against the use of steroids in the sense that steroids will activate the infection by reducing the host immune system, and it will inhibit the collagen synthesis and lead to corneal melting. Also, the use of steroids along with antibiotics, this will decrease the efficacy of antibiotics and will lead to a delayed epithelialization of the cornea. Now, this delayed epithelialization of the cornea with reduced host immune system, this will increase the risk of perforation, and in turn, this will increase the risk or the rate of therapeutic penetrating keratoplasty. Another thing, sometimes you are not sure about the causative organism. So if you are dealing with viral infection or fungal infection or protozoal infection, this will augment the scenario and will lead to more complications. For
solving this issue or solving this problem, there was a trial done, which is known as steroid for corneal ulcer trial, that's SCOT trial, trying to end up this debate. And this trial is a multicentric randomized placebo-controlled trial used for 500 patients. Try to answer all these questions regarding the usefulness of use of steroids along with antibiotics. The next slide, I will speak a few words about the SCOT trial and what are the final conclusions to answer or to solve this debate. So the SCOT trial tried to answer this question whether the use of topical steroids in a long term is beneficial in bacterial keratitis or not. As I said, the SCOT trial, which is a placebo-controlled trial, all patients, they will receive topical antibiotic, which is the moxifloxacin, used at least for 3 weeks. The initial 48 hours it is used hourly, and then after 48 hours it is used every 2 hours till reepithelialization of the cornea takes place. Then it is used 4 times a day for the next 3 weeks. So the whole duration of the treatment is 3 weeks. Now, all patients, they will receive antibiotic, but only half of the patients will be receiving topical steroids, and the other half will have placebo. The half which receive steroids, it is received after 48 hours, after the initial hourly drops of moxifloxacin, and it is used prednisolone phosphate. It is used 4 times a day for 1 week, and then twice daily for 1 week, and then once daily for another week. So the whole duration is 3 weeks as the duration of the antibiotic. This is the plan and the scheme of the SCOT trial, how they use the drops, either steroids or antibiotics. Now, when they follow the patients, the initial 3 months, there was no significant changes between the 2 groups that they use the steroids or the placebo. There was no much improvement, except in certain cases with severe corneal ulcer. I will mention about them. However, the changes or the benefits has been noticed after follow-up for 12 months. They found there is improvement in the visual acuity and the best corrected visual acuity in the subgroup, in the steroid subgroup, except those for who are suffering from nocardia. Nocardia has no benefit in the use of steroids in this trial. Now, another important thing is the timing of the treatment is very important, when to start the steroids and when to stop. And also, what I mean, there should be an antibiotic coverage during the whole period of the use of steroids, and steroids should be used at least 48 hours after the onset of the antibiotics. And this is very important. Also, the follow-up is very important to note what are the changes that happens during the treatments. Now, the conclusion of the SCOT trial were that patients with very poor presenting visual acuity due to a central corneal ulcer within the central 4 millimeter of the pupil, or people with very deep corneal infiltrate due to bacterial keratitis, these people, they benefit from the use or the adjuvant use of steroids along with antibiotics. So this is the main advantage of use of steroids in these people with very poor presenting visual acuity due to a central within 4 millimeter from the pupil with deep corneal infiltrate, provided there is bacteriological result in the hands that's due to bacterial and not due to nocardia or fungal or herpes infection. These people, they will benefit from the use of steroids. Another thing that there is no, the SCOT trial shows that there is no overall benefit from the steroids in a culture positive bacterial ulcer. So the benefit only, as I mentioned, in these scenarios, a very deep infiltrate and central corneal ulcers within the central 4 millimeter with very poor visual acuity. This is the only benefit of the use of steroids, or on the only indication. If this does not fit with the case, so better not to use steroids in these cases. As I said, that the subset with large central ulcer This is the one which benefit from the use of steroids, and it should be avoided and actually contraindicated in people with fungal or parasitic or viral keratitis. So that we speak only about bacterial keratitis with bacteriological result in the hand. So this is very important, and during the whole period, antibiotic cover should be present. The other thing that it is contraindicated, that is, as I said, in nocardia keratitis, in atypical mycobacterial keratitis, and in fungal keratitis, it should be avoided in these patients. Now, the importance of the Scott trial for every clinician, as well as for postgraduate students, this is very important questions in the postgraduate, in the master degree, or in the PhD. So the examiner might ask you about, what do you know about the Scott trials? What are the recommendations from the Scott trials? What are the indication of use of steroids in infectious keratitis, and so on? So I recommend every student and every candidate to read this trial carefully and be aware of what's the recommendation of the Scott trial.
Now we will speak about important aspect of the management of infectious keratitis, which is the surgical management in case of failure of the medical treatment. One of them is the use of the conjunctival flap. Now, the conjunctival flap provide tectonic support and vascularization of the affected area, and it should be used when after the use of broad spectrum antibiotics, and we make sure that there is no more infections on the surface of the lesion, so that this conjunctival flap will not be infected by itself. And the conjunctival flap, the disadvantage that it will compromise the vision, so it is preferably used when there is peripheral ulceration with melting and appendix perforations, especially at the limbus, near to the limbus, so that it will not compromise the vision. However, if there is impending perforation even in the central part of the cornea, it can be used to enhance the mitotic activity and the healing of the surface epithelium. The other thing is the use of amniotic membrane graft, as I said before, which is derived from the human placenta, can be present as a cryopreserved or in the dry form, and it is used on the ocular surface as a therapeutic bandage, along with a therapeutic bandage contact lens, and the top of it can be used, and it enhances, provide metabolic and mechanical support to the non-healing epithelium. And it is as the conjunctival flap should be used on a clean surface without evidence of active inflammation, otherwise it will be infected. Now, the other surgical interference is the keratoplasty. Now, when we I speak about keratoplasty, we mean therapeutic penetrating keratoplasty, or sometimes therapeutic lamellar keratoplasty if there is deep infiltration of the cornea without perforation. And we make sure with the OCT that we can do the lamellar keratoplasty, although the recurrence rate of the infection is high. However, the keratoplasty indicated in uncontrolled progressive infiltration with limbal involvement, that adjacent structure will be involved, and there is also evidence of microperforations or even perforation. It should be used to avoid the occurrence of endophthalmitis. As I said, the recurrence rate is high, and the complications that arise after keratoplasty can be worse, especially if it gets infected and or get rejected. So therapeutic penetrating keratoplasty or lamellar keratoplasty can be performed in acute microbial keratitis with difficult treatment, and is associated with higher complication rate and lower graft survival. And the aim of this surgery is to keep the shape of the eye, and later on, when the case gets stabilized, we can plan for another optical keratoplasty.
Now we come to an important alternative or adjuvant modality for the management of infective keratitis using the CXL, which is the cross-linking. Here we utilize the cross-linking not as the management of keratoconus, but it is used as anti-infective applications. There are long debate regarding the usefulness about the use of CXL in the management of infective keratitis. Some people, they are with the evidence that CXL improves and sometimes cure cases of infective keratitis, especially due to bacterial and fungal, and not due to viral keratitis. The other group of people who are against the use of CXL, they claim that the use of CXL will prevent the penetration and the permeability of the cornea to the drug, so they will limit further penetration of the drug inside the cornea. And also in some fungal infections where the organism is embedded inside the cornea, so there will be not easy to eradicate the organism from the cornea after cross-linking. So there is a long debate regarding the usefulness of cross-linking in the infective keratitis. However, there are some studies support this evidence, especially known as the type which is known as the BACCXL. BACCXL stands for photoactivated chromophores for infective keratitis. Some people, they use the riboflavin, and some others use the rose bengal as photoactivated chromophores. Another alternative modality for managing the infective keratitis is by using the collagen cross-linking. Now, the collagen cross-linking use in infective keratitis has been placed for a large debate between doctors regarding the usefulness of this modality of treatment in managing infective keratitis, especially superficial keratitis, namely bacterial and fungal keratitis. It has no role and are actually contraindicated in presence of viral keratitis. And the debate was the people who are supporting the use of collagen cross-linking, that by collagen cross-linking we are strengthening the outer stroma by creating a chemical bonds between the lamellae of the stroma, and this will prevent the proteolytic enzymes and minimize the digestion and the risk of perforation of the cornea, either because of the release of mediators from the infective organism itself or from the immune host system itself. The other points that supporting this evidence that they look to the duration of the management of the infective keratitis, especially the fungal keratitis, which might reach up to 6 to 8 months. So the need for alternative way of accurately sterilizing the cornea from the pathogen is very important, and perhaps the use of ultraviolet and cross-linking might be an alternative method. Another thing that infectious keratitis is one of the leading causes of preventable blindness, and the need for an accurate and precise management of the case is very important. So cross-linking solves this dilemma when you are facing a case that you don't know whether it is a fungal or bacterial. So by the use of ultraviolet, which is effective against both fungal and bacterial, so you can solve the problem and manage whatever the causative organism regarding without the need for waiting for the pathology or the microbiology lab for the result. And also by this way we simplify the management so that even a general practitioner in the outpatient department, he can immediately start the cross-linking of the cornea in such cases without the need for an expertise and an expert doctor who will judge about the case. Once you are sure that this is a case of fungal or bacterial keratitis, so immediately you can start your cross-linking. And one of the drawbacks on the management of the infectious keratitis is the cost. The cost of the management is high because you will keep on watching your patients and visiting you for a long period, up to 6 to 8 months. And this, for some people or poor people, is not affordable. And this might be one of the burden for the patients and lead to the development of blindness. So all these factors support the people who are saying that we have to use the cross-linking and we have to make more research on the cross-linking as a treatment tools in the management of infectious or bacterial keratitis. Now, the other partner or the other party of the debate that against the use of cross-linking, saying that by cross-linking we are increasing the bonds and the tightness of the outer stroma, and this will reduce the permeability of the antifungal drug, which already under minimum concentration inside the cornea, and the bioavailability of the antifungal drugs will be
threatened. So this will retard the effectiveness of the antifungal or antimicrobial drugs in the management of the pathogens. So they suggest not to use the cross-linking. So till now, there is no strong background clinical evidence regarding the usefulness. There are some studies supporting this, and some are still still running. We are waiting. A large randomized controlled trials is running in different parts of the world, multi-centers, regarding the usefulness of this type of modality, which is named as PAC-CXL. As you know, the PAC-CXL stands for the photoactivated chromophores for keratitis, and there are initial results supporting the usefulness of cross-linking in these cases, especially in superficial keratitis, either due to bacterial or due to fungal keratitis. Some studies shows that complete cure with complete shortage of time in the management of the case on just pure CXL treatment without any adjuvant therapy with antimicrobial or antibiotic treatment. So till now, there is no strong evidence, but different randomized controlled trials, multicentric, are running, and we are awaiting the result for this modality of treatment regarding its usefulness in the management of infective keratitis. Now, the photoactivated chromophore for infectious keratitis, or the PAC-CXL, is one of the modalities for the management of infectious keratitis. As you know, the corneal cross-linking received the FDA approval as a minimally invasive intervention that utilizes the ultraviolet and the riboflavin. And the goal for the CXL is to increase the degree of cross-link between the lamellae of the outer stroma, and will provide a sufficient mechanical stability. So by utilizing the riboflavin along with the ultraviolet A, significantly increases the tensile strength and the biomechanical resistance to collagenases, either from the pathogen itself or from the host immune system itself. Apart from this, the cross-linking has an antimicrobial effect, and that's why it is used in the microbial keratitis by activating the photoactivated chromophores, which will be bound to the DNA of the organism itself and lead to retardation of the multiplication of the organism. Also, the ultraviolet A itself has an effect on the DNA of the organism. And also by the release of the reactive oxygen to the cells, so this also will lead to the damage of the pathogens. So there are various protocols for various organisms, and it is mainly used.
Now I will speak about how to deal with a case of corneal thinning or melting, or even corneal perforation. Now, the recommendation that if you have corneal thinning, which is about to perforate, the first thing is to stop any drugs that enhances the collagenolytic activity, namely the non-steroidal anti-inflammatory. It is totally prohibited to use the non-steroidal anti-inflammatory drugs in the presence of corneal epithelial defect. This will enhance the collagenolytic activity and increase the melting of the cornea. The second thing, there are some claims that the use of doxycyclines or the tetracyclines, they have anticollagenase activity, and this will enhance the healing and also prevent the melting of the cornea. Although there is no strong clinical evidence support this issue, but there are some papers by some doctors that doxycycline will improve or stop to some extent the evidence of corneal thinning. Now, in case of there is an impending perforation, so you have to do either a tarsorrhaphy, that's to promote the healing of the corneal epithelium, or to use the amniotic membrane graft. The use of the amniotic membrane graft, as you know, there are two types of the amniotic membrane, can be cryo stored or dry amniotic membrane. The main thing that you should not use the amniotic membrane in the presence of active bacterial infection, because it will enhance the growth of the organism. It should be used when clearly there is no evidence of infection has been cleared out, and only that you have thinning. So the use of amniotic membrane will enhance the healing of the epithelium. Now, if there is evidence of microperforations or perforation less than 2 millimeters, so you can use the glue or use the bandage contact lens as a support to the epithelium, as you can see in this picture, this one. So you can use the bandage contact lens after being soaked with antibiotics, and you can use the glue. Now, if you have a large perforation, so there will no way to do unless that you do therapeutic penetrating keratoplasty to preserve the content of the eye and prevent the occurrence of endophthalmitis. Now, after finishing the bacterial keratitis and we understood the different ways of diagnosis and management and bacteriological assessment, I would like to discuss some special form of microbial keratitis that need a special treatment and need special attentions. The newly emerging one is the Pythium keratitis, and also the Microsporidia keratitis and Acanthamoeba keratitis. In the coming slides, we'll speak about these three, paying more attention to the Acanthamoeba keratitis because this is one of the becomes more prevalent with the prevalence of the use of the contact lenses. So Acanthamoeba should be understood very well.
One of the specific microbial infectious keratitis that needs specific treatment is known as the Pythium keratitis. Pythium keratitis is one of the emerging keratitis, which is rare actually, common in the places where there is a rainy seasons and exposure to the tape water. And the significance of this type of keratitis, that is the delayed presentation and delayed initiation of treatment, because it resembles fungal keratitis and resemble viral keratitis. Now, this keratitis is caused by a parafungus. It is not a fungus, it is a parafungus omicide known as Pythium insidiosum, which is highly mobile, present in the still water. And it has specific clinical presentation that differentiated and actually pathognomonic for its this keratitis, which is known as thin-tile-like projections from the lesion. You'll find this lesion similar to the fungus. However, there is a thin-tile-like projection. Thin-tile means a shira. And also peripheral guttering. You see, there is depression on the periphery of the cornea, similar to the Morin's ulcer or Tieren's marginal degeneration. Similarly here, there is guttering. And also here, there is a beginning of the guttering. So this is pathognomonic. These two findings are pathognomonic. That's the thin-tile-like projection, which is seen in more than 50% of the cases, and also the peripheral guttering in more than 40 to 50% of the cases. So if you find these two things, you should revise your treatment and think of Pythium keratitis. In the laboratory investigation, it is ribble-like, similar to the hyphae of the fungus, but it is not a fungus. And it has a minimum septi. This is known by microbiologists. And it grows very well on the blood agar, which shows the zoocyst. This is the zoocyst. Now, the zoocyst is pathognomonic also in the laboratory investigations. Similarly here, you can see it can present as a plaque, which is similar to the fungal keratitis, but it is not fungal. But you can see clearly here, there is guttering. There is peripheral guttering. So this is pathognomonic for Pythium keratitis. Similarly here, the thin-tile-like projections of the lesions. You'll find thin-tile-like projections. Similarly, you can see a severe reaction with hypopia. It is a slowly insidious form of keratitis, not responding to the traditional treatment, not responding to the antifungal treatment. That's why you should think in the Pythium keratitis and start its specific treatment. Now, as far as the management of the Pythium keratitis, there is no standardized protocol for the management, but most doctors who are have experience with the Pythium keratitis, they advocate the use of topical linezolid hourly, along with oral azithromycin 500 milligram. Some people, they add this antifungal like the itraconazole and voriconazole and topical azithromycin. But usually topical linezolid hourly along with oral azithromycins. You should remember that this is very aggressive infection, and 50% of the cases end up by therapeutic penetrating keratoplasty or even evisceration or inoculation, because some report cases that there is extension to the brain and even it can cause death. So when you plan for therapeutic penetrating keratoplasty, you should plan it early before full involvement of the cornea, so that the recurrence will be high. So you should plan for therapeutic penetrating keratoplasty early if you fail in the control of the infections. So this is the Pythium keratitis, should keep it in your mind. Now the other specific infectious keratitis that need specific treatment is the infectious keratitis caused by microsporidia. Microsporidia defined as intracellular eukaryotic spore-forming parasite that previously was described to involve immunocompromised patients as opportunistic infection. However, recently has been discovered even in immunocompetent patients, and even more, it might have a systemic involvement in the form of encephalitis, and sometimes can lead to the death of the patient, especially if immune compromised. So the microsporidia has a specific presentation. It can present either as a keratoconjunctivitis or as stromal keratitis. Usually stromal keratitis reserved for patients who are immunocompromised. However, in a healthy patient, usually present as a keratoconjunctivitis with a characteristic chalky white deposit on the surface of the cornea that can be removed by cotton buds, and this make it confusion with viral keratitis. And also the differential diagnosis is the Thygosome punctate keratitis, in which there is some deposits on the surface of the cornea, but in Thygosome usually has a recurrent course, and usually the eye is white, unlike the microsporidia. So the characteristic feature of microsporidia is a coarse punctate epithelial erosions, which is known as a chalky white appearance, or described as a stuck-on appearance. Rarely, it might have also a stromal reaction with pigmentation on the endothelium. Now, as I said, that it might be confused with the subepithelial infiltrate in viral keratitis. So by OCT, it can be differentiated. This is the subepithelial infiltrate seen in adenoviral keratitis, and this is the microsporidial keratitis, in which there is superficial deposits on the surface of the cornea. Now, the good thing that before they thought to be should be treated as a fungal with antifungal treatment for the keratoconjunctivitis, but it is found that it is self-limiting, and within 1 or 2 weeks it will improve even without treatment. Similarly, here you can see the picture. This is the stuck-on appearance, or the surface. The spores can be removed with the buds. You can see, you can just remove them and send them to the histopathology. But generally, it has a benign course as a keratoconjunctivitis, and it can resolve with 1 or 2 weeks even without treatment, unlike the stromal keratitis that I will explain about in the next slide. Now, for the stromal microsporidial keratitis, this is a serious infection, and usually it involves immunocompromised patients in comparison to the stuck-on appearance, as we have explained in the keratoconjunctivitis. The stromal infiltrate takes many shapes, as a diffuse stromal infiltrate, or even corneal abscess and melting, and even perforations. And as I said, it might be also associated with systemic infections. And this type of keratitis should be aggressively treated. Many medications have been tried, including topical PHMB and chlorhexidine, and also oral albendazole and ketoconazoles. Of course, when you use the ketoconazole, you should make sure about the liver function test. And ketoconazole, it has some liver toxicity, so you should make sure that your patient is not vulnerable to liver failure. Now, the most of the cases with the stromal microsporidial keratitis, even with aggressive treatment, they end up by therapeutic keratoplasty, that you need to do a therapeutic keratoplasty to avoid the dissemination of the organism inside the body. Now we come to one of the most common exogenous source of infectious keratitis caused by Acanthamoeba keratitis. Acanthamoeba is a parasite or free-living organism. It derives its name from the Greek word acantha, means spikes, and amoeba, which is the amoeboid movement. So it is like the amoeba, but with and this acanthamoeba, as I said, is a free-living protozoan, can be found in many places, in the distilled water, in fresh water, in salt water, and even in the Antarctica, and even in the air conditioning units, and in the soil, and in the sea, and even found as a commensal in the mouth of human beings. And it is responsible for a wide range of diseases to the human being, especially in immunocompromised people, especially encephalitis and also lung infections, and in immunocompetent people like infectious keratitis and the people who are using the contact lenses. So it is a free living organism present and available in a wide range on the environment and also in the agriculture and even in the vegetables and the refrigerators. So it is available over a wide range in the environment, and it has two main forms: the trophozoite form, which is the active and infective form, and the encysted form, which is the inactive form when there is in suitable conditions of humidity and temperature, so it will be in the encysted form. However, when the nutrition is available and temperature is suitable, it will be in the active and the infective form, which is the trophozoite. So acanthamoeba in immunocompetent people is a rare disease, but it can be seen as infectious keratitis, but it is also common in immunodeficient people, as I said, in the encephalitis and lung infections. And once invading the cornea and the stroma, it will produce severe inflammatory reaction and release of proteolytic enzymes, and treatment can prolong up to 6 months for the treatment. And even with the treatment, 25% will be having a corneal blindness and require subsequent optical or therapeutic keratoplasty. And there is a wide range of resistance to the traditional antibiotics. So there are certain special antibiotics or antimicrobials are used in the treatment of this disease. And sometimes the therapeutic keratoplasty is inevitable. Now, as I said, that there are two forms, which is the trophozoite form. You can see this is the spikes, and this is the trophozoite form. This is the active and the infective form. And it has many shapes because it changes its shape from the name. As I said, it is amoeboid, and usually it keeps on changing from the active to the inactive form, which is the cyst form here, which has a double layers, and this is based on the environmental conditions. Another thing that there are nearly 17 genotypes from the acanthamoeba, and termed as T1, T2 up to T15 has been recognized. And T4 is the one which is responsible for 90% of all of the infectious keratitis. So based on the genotyping, the T4 is one of the most common cause of infectious keratitis. The others, like T1 or T3, responsible for skin infections or lung infection or brain infection and so on. So this is important postgraduate questions in the MCQ. That's T4 is responsible for 90% of the all infectious keratitis by acanthamoeba. Now we come to the risk factor and the predisposing factor for infectious keratitis caused by acanthamoeba. Number one comes the contact lens wearers. People who are using contact lenses are more prone. As I said, since it is a free-living amoeba, so it is available even in the contact lens solutions and can invade the cornea. And precipitated by trauma, of course. It cannot invade intact cornea unless there is a trauma. Also, people who are exposed to contaminated waters or solutions, also history of corneal trauma is very important. And people who has done orthokeratology, as you know, the orthokeratology is meant to correct the refractive error and correct the shape of the cornea. So there will be tight application of rigid contact lenses on the surface of the cornea, and this will lead to sometimes hypoxia and ischemia to the cornea, and as a result it becomes more vulnerable to the gate infection by acanthamoeba. Also, any people at any age are prone, and also there is no sex predilection, so both male and female can be involved. As I said, people who are immune deficient are more prone for other human infections like encephalitis and pulmonary infections. Now, the clinical manifestation of acanthamoeba have a very wide range of clinical presentations based on the presentation of the patient to the doctor. It can range from just simple epithelial changes to a severe suppurative stromal infections with suppuration and even with perforation. So we can classify the clinical presentation into an early stage, advanced stage, and late stage. When you look to the early stage of the disease, as I said, the main feature of this stage that you will find a disproportionate between the signs and symptoms and the finding in the cornea. So you'll find a severe pain in the patients complaining of severe pain, but when you examine the cornea, you'll find very mild epithelial infiltrate. Also, you'll find severe congestion, but you will find the corneal pathology is very minimal. This is characteristic feature, especially in immunocompetent individuals. However, in immune host suppression or people with immune deficiency, sometimes you'll find a silent acanthamoeba that there is no pain. The early stages, you will find a variety of changes in the cornea in the form of ocular just ciliary congestion or roughness. This is very early sign. That is, you will find very irregularities and roughness of the surface of the epithelium. If the patient is present in this stage, it is very, very early and you can treat it very quickly. You will find very different epithelial defects, subepithelial infiltrate, recurrent corneal erosions, pseudodendrites. When we say pseudodendrites, the normal dendrites which is seen in the viral infection, characterized by arborizing and branching epithelial defects with terminal patterns or terminal expansion. In the pseudodendrites, you will find the same arborizing branching epithelial defect, but without the terminal expansions. And sometimes when you use the fluorescein dye, the fluorescein will sink and go inside the stroma. And this is very peculiar when there is perineuritis, as I will show you later. So the clinical presentations has a variety. For example, this is a epithelial pseudodendrites, as you can see here. And this is, you can see the tracks. This is the track of the inflammation within the stroma following the nervus, which is a perineuritis, as this one. You can see it on the slit lamp. And similarly here, this is the fluorescein staining. You can see the pseudodendrites present in the epithelial fluorescein staining. Same thing here. This is the radial keratoneuritis. You can see the fluorescein is tracking and going deep into the stroma. This is very peculiar and associated with severe pain. Similarly here, subepithelial defect, and this is also like a keratitis in the stroma and infiltration inside the stroma. Disciform keratitis also is a feature. That's why acanthamoeba is sometimes confused with viral keratitis, because nearly the same finding in viral keratitis, you can find it in acanthamoeba. So this is a disciform keratitis, and the problem is that if you don't have detailed history of the patient and you use steroid in this patient, there will be worsening of the situation. History of trauma is very important. History of use of contact lens is very important in these cases. Now we come to the advanced stage in which the inflammation will go more deeper in the stroma and the corneal ulcer will reaching more than 5 millimeter. And there will be severe necrotic tissues and severe inflammatory reaction in the stroma and around the nerves. Patient will complain of severe pain, and the ring infiltrate will become more evident, as you can see here in this picture. So there will be deep stromal infiltration and scarring and severe pain formation in this patient. Similarly, if you can see here, there is a clear cut, the corneal rings is, or the corneal infiltrate start to be formed with severe congestion of the eye, and also hypopium formation here, as you can see. Corneal infiltrate and severe pain, and you can see the ulcer formation is much more, and even corneal abscess start to be formed. So this is advanced stage, and the patient will complain of marked drop of vision and severe pain inside the eye and severe inflammations. The last stage, which is the late stage, characterized by corneal ulceration more than 8 millimeter, with severe inflammatory infiltrate within the stroma, and the ring infiltrate will becomes very evident, and even hypopium is clear, as you can see here in this slide. And even extension of the inflammations toward the sclera with the formation of scleritis. You can see here the ring infiltrate very dense and very advanced with the severe thinning of the cornea and even perforation, as you can see here. Sometimes the intraocular pressure get elevated with secondary glaucoma, severe pain, which is known as ophthalmodynia. And you can see here, similarly, the scleritis involvement of the corneoscleral junctions with the scleritis and hypopian formation. This is the features of very late stage. Now, for a definitive diagnosis for acanthamoeba keratitis, you should back up your clinical finding with your laboratory investigation. It comes in the top is the corneal scraping. The corneal scraping should be done for staining as well as for culture, and should be from the cornea as well as from the contact lens itself and its solution. Sometimes in the presence of a negative corneal scrape on a strong evidence clinically that it is a case of acanthamoeba keratitis based on the history, we go for corneal biopsy that I have explained before. The other thing is the use of confocal microscopy. This is very sensitive investigation for acanthamoeba. However, it is not that high specific, and it is very expensive investigation. It is not available in most of the hospitals. Should be available in a very high tertiary centers. And the last but not the least is the PCR. PCR stands for the polymerase chain reaction. This is very specific and very sensitive investigation that help you in the diagnosis of acanthamoeba keratitis. Really, for a good yield of your investigation, a combination of the corneal scraping or the corneal histopathology along with the confocal microscopy and the PCR, all of this will gives you a very strong evidence for acanthamoeba keratitis. Now, in acanthamoeba, we look for the trophozoite, which is difficult to distinguish sometimes from the macrophages. As I said, the trophozoite has different shape because it is a free-living amoeba and it has a free movement, and so the organism will have different shapes. However, the cyst, usually the inactive form, will be polygonal in shape, like this. This is the cyst. The stain with the cauliflower white with the methamine silver or the periodic acid shift stain. You can see the purple color in the periodic acid shift stain. This is the double wall of the cyst, and this is the green fluorescence of the cyst and cauliflower white. So this is very important investigation to memorize for the accurate diagnosis of acanthamoeba keratitis. Now, as I said before, that the clinical presentation of acanthamoeba has a very wide range of presentation that make it sometimes confused with viral and bacterial keratitis, and purely based on the clinical finding might not be enough to reach to the definitive diagnosis of acanthamoeba, and we have to go for the microscopic or microbiological investigation. However, clinically, when you look to the risk factors for acanthamoeba, usually acanthamoeba preceded by trauma or history of use of contact lenses, as compared to the viral keratitis, which is usually preceded by fever or some evidence of emotional stress. Also, in the corneal signs, you will see true dendrites in the viral keratitis, or sometimes you find geographical ulcer or marginal keratitis. And the true dendrites are branching, arborizing epithelial defects with terminal pulps or expansion. In contrary to the pseudodendrites, in which you find branching, arborizing defect in the epithelium without terminal expansion. And if you use both the fluorescein and the rose bengal, the dendritic ulcers will show the edge of the ulcer will be stained with rose bengal, in which it contains the devitalized epithelium, which is hosted by the virus. However, the epithelial defect will be stained by fluorescein. And of course, with antiviral treatment, there will be no improvement in acanthamoeba. However, there will be improvement with viral keratitis. Now, if we compare the acanthamoeba with fungal keratitis, both of them, they might be very similar, especially in the history. Both of them, they will have history of trauma or history with organic objects. However, and also both of them, the clinical history, they will have slowly progressive insidious course. However, the acanthamoeba usually preceded by epithelial punctate keratopathies with the pseudodendrites, usually no purulent infiltrate, just a gray infiltrate in the stroma, and in later stages you will find a ring infiltrate. and usually there is no satellite lesion. Now, this satellite lesion is very peculiar to the fungus. Both you have two signs, the satellite lesions as well as the feathery appearance of the corneal ulcer is a features of the fungus. However, abscess formation can be seen in fungus, and in acanthamoeba, in bacteriological examination, you will find the cyst. In the fungus, you will find the hyphae. Another thing, in the presence of hypopyon, as we said before, that in the fungal keratitis, usually the hypopyon pyramidal in shape, fixed, not respecting the movement of the head or the eyes, unlike in the bacterial or acanthamoeba keratitis. Now, if we look to the difference between acanthamoeba keratitis and bacterial keratitis, also the history might be the same because when I speak about bacterial, mainly I refer to the Pseudomonas, because both acanthamoeba keratitis and Pseudomonas keratitis can present with a ring infiltrate. So a ring infiltrate is a differential diagnosis. One of them is the Pseudomonas. However, in the bacterial keratitis, usually the Pseudomonas have a very rapid deterioration, unlike the acanthamoeba, which is a little bit slow as compared to the bacterial keratitis. So it has a subacute or chronic course, unlike in the bacterial keratitis. And as I said before, the aggressive anterior chamber reaction is seen in bacterial keratitis with hypopyon formation. Usually the corneal infiltrate is in the form of haze and grayish infiltrate. There is no or minimum ulcer, mean abscess formation in the stroma as compared to the bacterial keratitis. Similarly, the necrotic ulcers sometimes is purulent in bacterial keratitis with yellowish oxidation, so that differentiated from acanthamoeba keratitis. And response to antibiotic, of course, the bacterial keratitis will shows improvement in antibiotics. However, acanthamoeba, it will not improve with traditional antibiotic, and it should we should use antimicrobial specific for acanthamoeba. This is just a general overview for the different points, how we compare with between acanthamoeba keratitis and bacterial and fungal keratitis. Again, this is some of the important clinical signs that help you as a clinician or as a postgraduate student to differentiate between bacterial, acanthamoeba, and fungus. And when we say bacterial, I mean mainly Pseudomonas. Now, as I said before, in bacterial keratitis, the sequence of events might be very rapid, and you will find severe anterior chamber reaction, and you will find even the pain will be very rapid, and the ulceration is very rapid. Now, in acanthamoeba, the pain is very severe, but it is slowly insidious. That is, it is not in the first day that you find severe pain, and usually there is no ulceration unless in late stages. In the ulceration, usually the corneal lesions start as epitheliopathy or pseudodendrites or perineuritis, and the ulceration is very late signs. Now, in the fungal keratitis, also the ulcer will appear early, and also it has a slowly progressive insidious course. But the peculiar of fundus is the lesion that usually elevated and forms plaques like this, elevated lesions with serrated margins, and it has a satellite lesions that's multiple corneal infiltrate adjacent to the main infiltrate. So this is suggestive of fungal lesions. So you should keep this in your mind that these features you can find in 50% of the cases of the fungal keratitis. They have a feathery appearance. This is the feathery appearance, like the cotton, and the serrated margins, and they have presence of fibrin in the anterior chamber. As I said, that the hypopyon is pyramidal in shape, not respecting the head movement, and you find the satellite lesions. You should memorize all these differences, very important. Now we come to the drug which is used as anti-amoebic drugs in the treatment of acanthamoeba keratitis. The most famous is the aromatic diamidines. These aromatic diamides, there are 4 categories of this as anti-amoebic drugs, which mainly inhibit the amoeba, acanthamoeba keratitis. But these are not as famous as the other category, which is the cationic biguanides as a disinfectant, especially the chlorhexidine and polyhexamethylene biguanides. This is very commonly used. Also the imidazole group, which is the ketoconazole, fluconazole, meconazole, and clotrimazole. And these should be used in combination with cationic biguanides. So chlorhexidine and polyhexamethylene biguanides are considered as very effective in killing the acanthamoeba trophozoite and cysts. However, the imidazoles are used as adjuvant therapy along with the biguanides or cationic biguanides. This is the main medication for acanthamoeba. The last but not the least is the miltefosine. This drug primarily was used orally in the treatment of as an anti-leishmania drug, and it has been found in animal model as well as now is applied in humans that it is very effective as anti-acanthamoeba. Can be used as orally, and also now there is also a topical preparation of about 65 microgram per ml. It has been used in animal models and even in human that within 28 days result in complete cure of 85% of the cases of acanthamoeba in hamster models. So it is a new drug and it has very promising result in curing from acanthamoeba. Now the same question arises in the management of infectious keratitis caused by acanthamoeba is the role of steroids. It is generally recommended not to use corticosteroids in initial cases of acanthamoeba, and the steroids there has no inhibitory effect on the amoeba pathogen itself. However, in the presence of improvement in the condition after the use of anti-acanthamoeba agents, and the diagnosis is proved by microbiology, and after very clear evidence of clinical improvement, and after recurrent corneal scrape that there is no active trophozoite or oocyst within the specimen, at that time you can use corticosteroids to minimize the inflammation and also useful in minimizing the pain during acanthamoeba keratitis. This is the only indication that after repeated negative smears from the cornea regarding the trophozoite for acanthamoeba, and after very clear clinical evidence of improvement of the patients, and after a strong bacteriological or microbiological diagnosis of the case as acanthamoeba, at that time you can use steroids after the cover or on the cover of anti-amoebic treatments. Now, this is a case of fungal keratitis, which has a feathery appearance with a branching pattern like this. It mimics a herpetic keratitis. But the difference than herpetic keratitis, that is the area in between this branching is not clean. When you look to the herpetic keratitis, you will find between the branching knobs, the stroma is clear. However, here it is not clear. It is feathery appearance like this. Now, the problem that if in such case you start with topical aceclopar, as you know that aceclopar has epithelial toxicity, and after application of aceclopar in a case like this, which is a fungal keratitis, there will be a rapid deterioration of the case and rapid spread of the infection. So now what's the solution? You are not sure whether it is a herpetic or fungal keratitis. So as you know that the general trend now towards the use of minimum drops to the eye, and especially if you are going to give an antiviral, better to give a systemic oral antiviral, as they found that they have reached the same concentration within the epithelium and the cornea as topical drops. So the ideal management in this case is to use topical antifungal like natamycin, and then use oral aceclopar so that you can have coverage for antiviral spectrum as well as antifungal spectrum without inducing toxicity to the epithelium. Now, by this level, we reach to the end of this lecture. I hope that I could simplify certain things regarding the bacterial keratitis and some other forms of keratitis, and simplify the management of these cases and how you will approach the case. And by the end of this lecture, I hope that I will meet you in the next lecture, which is regarding the viral keratitis and fungal keratitis.
The reference is available at the end of this lecture, so you can see the references, and the lecture will be available in the links that's shown in the end of this lecture. For that time, I hope that you will be safe, and looking forward to meet you in the next lecture regarding viral and fungal keratitis.